السلام عليكم.
وعليكم
وعليكم
السلام.
السلام دكتور هاني.
وعليكم السلام sir.
Okay, guys, today inshallah we'll continue procedural skills, supervision and teaching also. So this is the part 2. For new members, you have 3 stations for complex stable patient, means history or psychiatry toxicology. Answer questions 2 stations, resus 2 stations, injured patient 2 stations. It means examination. Pediatric emergency medicine, so 1 pediatric history taking. Procedural skills, 2 stations. And supervise and teach, also 2 stations, so 4 stations now. Complex challenging situations, 2 stations, means communication station. The most important domain, clinical reason decision making, means the management plan. The second important domain, communication skills, your attitude in the room, the way you are talking, the way you are listening, the way you are teaching also. So including rapport, empathy, sympathy. Okay. So your attitude inside the station, very, very important. Will give you high score. Organization, motorization skills, you should be organized. We finished already history taking for new members, guys. We finished already history taking, psychiatry toxicology stations, resuscitation, practical skills. Inshallah, we can finish within 2 sessions. System and joint examination, it will take 2 sessions. Communication, maximum, inshallah, 3 sessions. After that, we will go for interesting mock exams till the exam, inshallah. And regarding the mock exams, we will try to make like every day if we can. If we cannot, it will be 3 days per week.
Sir, it will be better to mark exam like in a shelf, like history and them like one by one. If we mix mock exam,
Yes, we will make shuffle.
a shuffle of type.
Yes, shuffle mock exam. So you are not aware about the next station, okay? Okay, accuracy, the most important domain here is the checklist. It means the general approach. Okay. Skillfulness, you should be fluent, and supportiveness, you should be supportive. It means rapport, empathy, sympathy, check comfortability, pain, posing, explain in plain English, non-medical terms, and so on. Efficiency structure, you should be organized, and safety, good and correct management. Okay, in most of procedures, it will be teaching. They will give you junior doctor or junior nurse, and the mannequin or patient. Most of them mannequin. Okay, so it will be verbalization. You are not expected to do the procedure. Okay, so just the demonstration, you will verbalize. If the examiner asks you to do, no problem, you can insert the cannula. You are not expected to find the blood coming out or anything. No, you will do just the steps. Okay, so you can divide the station into 3 parts: pre, during, and post. So the general approach of teaching, you will say, I'm Dr. blah, 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 one of the ED senior. May I know your name and grade? I believe you have something to discuss with me regarding blah, blah, blah. Right? Yeah. Nice topic. How much do you know so far about this topic? Understand. The second question, anything specific you want to know? and stuff. Then go for learning objectives. You can say, today I will set learning objectives for you. I will teach you blah, 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 blah. I will teach you the indication, contraindication, complication, how to prevent and treat complication, the preparation, procedure, post-procedure management, post-procedure advice and follow-up, and documentation. Is that okay with you? You will say okay. Clear, guys, the general approach?
Yes, Dr.
Yes,
Yes, sir.
Yes, sir.
Okay. Here you can add alternatives if applicable, not on all stations. That's why I did not put here. So you can add alternative. Okay. Regarding preparation, it means the preparation of the patient, preparation of the doctor, preparation of the equipment. How many preparation now?
3.
Three. Preparation, patient, preparation, doctor, preparation, equipment. Okay. Preparation of the patient means the position of the patient and the position of the area, the landmarks. Okay. For example, arterial cannulation. So you will prepare the patient in lying position and the hand or the wrist in dorsiflexion. Okay. What about chest drain? You will prepare the patient in lying position and his hand behind his head, exposing the safe triangle, and so on. Then preparation of the doctor means washing hands with PPE. Preparation of the equipment, you will verbalize the equipment. You will find inside the room, just verbalize the name. Okay. So we have for practice Naveed, Shwarya, Yara, Kashif, Muhammad, Shati, Imran, May, Uzair, Zamrad, Khalid, Dian, Rudra, Afshan, and Amr. Okay. So the last session we practiced chest drain, open technique, and the Seldinger technique. Now we will practice for Naveed.
Yes, sir. Assalamu alaikum.
Alaikum assalam. We will practice for Naveed. It will be pleural aspiration. It means aspiration of air or fluid. Okay. So I will ask you to teach the junior doctor or junior nurse how to aspirate air. Clear?
Okay, sir.
Ishwarya,
Yes, sir.
you will teach the junior doctor or junior nurse how to aspirate fluid.
Okay, sir.
Okay. So here regarding chest drain or needle aspiration, so in chest drain it will be in safe triangle, but needle aspiration it will be where?
Mid-clavicular line.
Second intercostal
Second
space.
intercostal space.
Second intercostal
Second.
space, mid-clavicular line. Okay, excellent. Regarding area, fluid aspiration, I mean in pleural effusion. So for Naveed, the indication to drain air in spontaneous pneumothorax, right? For
Yes,
Ishwarya,
sir.
you will drain fluid for tap, for lab, and for pleural effusion. Okay?
Yes,
So
sir.
the example to know the diagnosis and also to aspirate fluid to relieve symptoms. Clear?
Yes, sir.
So diagnostic therapeutic. And your landmarks, it will be in the back. You will drain fluids in the back of the patient. So it will be between 7, 9 reps. 7th and 9 rep. Okay? It will be
Yes, sir.
between posterior axillary line and mid line, the posterior midline. Okay? Of course, ultrasound for both of you. Regarding Naveed, the indication for spontaneous pneumothorax, We have primary or secondary. Primary if the size more than 2 centimeter or breathless. So you will aspirate. The cannula 16 or 18 gauge, and you will aspirate maximum less than 2.5 liter. The second option, if the spontaneous pneumothorax secondary and the size 1 to 2 centimeter, so you will aspirate the C. Clear now?
Yes, sir.
Okay. Contraindication, if the patient needs
Chest
chest
drain.
drain. If the patient needs chest drain, it's absolute contraindication, right?
Yes, sir.
Relative contraindication, like coagulopathy, refusal, anything like that, allergy, like that. Okay. So for Swaria, the maximum, how much fluid aspiration?
1.5.
1.5. Both of you until the patient falls. At any time the patient cough, you will stop. Okay. So Naveed, you have 30
Yes,
seconds
sir.
and then 6 minutes.
Okay, sir. Can I start, sir?
You can start.
Good morning. I need to wash my hand. We are PPE. My name is Dr. Naveed, one of the ED registrar. May I know your name and level, please? Nice to meet you. I believe you have something to discuss with me, right today? Hello? Okay,
Proceed. If the
I
actor is
believe you have
silent, proceed.
I believe you have something to discuss with me today regarding the pleural aspiration. Okay, it's fantastic. It's really a very important practical skill we are doing every day in emergency department. So, how much do you know so far about this topic? Anything specific you want to learn, or we will start from the basic? Okay. So, where is the patient? Patient is okay. Okay. So let us set our objective learning objective today. Today I will teach you the indication, the contraindication, the complication, how to avoid and treat the complication, then the procedure itself, preparation of the procedure and the procedure itself, and post-procedure management advice and documentation and follow-up. Okay. So first of all, we will talk about the indication. So the indication for the this pleural aspiration, if the patient have primary spontaneous pneumothorax and the size is more than 2 centimeters, or the patient breathless. And the second one, if patient have secondary spontaneous pneumothorax and the size 1 to 2 centimeters. And the contraindication for this procedure is if patient who bilateral spontaneous pneumothorax, the patient is unstable or patient is hemodynamically unstable. There is also one contraindication if there is secondary spontaneous pneumothorax in size 1 to 2 centimeters, and the patient is breathless. So also at the end, I will give you some good website and videos and to teach you more. And every day I will teach you in the home also. You can repeat this every day. So first of all, before the complication, what the complication? The complication to in the contraindication there may be infection. There may be the infection at the overlying site, or there is bleeding disorder. The contraindication is if there is an infection at the injection site and there is coagulability. Okay, and So first of all, we will ask the patient take some history data from the patient, ample history. What is his allergy and last time when he ate and any previous past medical disease like that. Okay, and the precaution. So how to avoid the complication, and the complication the patient will keep in the resuscitation room, and we will clean the site of insertion, and we will give some painkiller if the patient is in the pain, and we can also use ultrasound guide, and we will also prepare a intraliver immersion if patient develop any local toxicity. Okay. Let us go to the procedure now. So let us to prepare our equipments. We should prepare our equipment, a large bore cannula, syringe, three-way tape, large syringe, sterile drape, sterile gas, and sterile swab. Okay. So before go for this procedure, first we'll examine the patient. We'll go for the 8 points of the breathing. What about the SpO2? What about the RR? We should do inspection, palpation, percussion, auscultation. And did you understand me? Are you following me? Everything clear for you? Okay. So the position of the patient, you know how we'll do the position. Patient will be supine position, and the hand, the left arm will be below the cap, below the head, Okay. So also we need to clean our hand and wear PPE, and also we need clean place a drape over the area. Which area? The landmark. Which is the landmark? The second is the pass space mid-clavicular line. We will place a drape, make a hole in the center, and we will infiltrate local anesthesia 3 milligram per kg ultrasound guided to numb the area. Okay. So we'll do the procedure. We will need one after the exploitation of the anesthesia. We will wait for 1 minute to numb the area. Then we will insert one 18 gauge cannula attached to the 10 ml syringe in the normal saline and in the mid-clavicular line above the second rib. Okay. So first we will aspirate. Okay. If there is air coming, so it means it's in the pleural space, the needle. Okay, so after that we remove the needle syringe and we will attach the cannula to start connecting piece of tube and three-way catheter. Okay, and we will aspirate 550 ml and they will turn the tape towards the air and we spill air into the atmosphere. Okay, we turn the tape again and aspirate again another 50 ml from the pleural cavity. We will continue until we draw 2.5 liter at the patient cough. Okay, and after the procedure, we also need to repeat the chest X-ray again. We need to check the wet side. We need to re-examine the patient. All the 8 points: inspection, palpation, percussion, auscultation, saturation, and RR. Okay, so did you follow me? Are you with me? So what I told you. So landmark for needle aspiration, secondary first space, mid-clavicular line.
Thank you.
Only 10 seconds to finish my station. Can you give me?
Okay, thank you, Naveed. What do you think, guys? How many marks will give Naveed?
15 out of 10. Excellent.
No. I'm waiting for you, sir.
Mashallah, you performed very well.
What do you think, Naveed?
I go a little bit in detail, so I should. I did not finish my task. This is a problem.
You are doing well, but you are rushing too much in the end, so no need to rush in time. Okay. So
Okay,
in teaching, try to give concise information, organize the steps. Okay.
Okay, sir.
And also try to not slow, at least normal tone. Okay.
Okay, sir.
Because teaching, anyway, we are practicing within 6 minutes. In the exam, it will be 8 minutes. I think you covered almost all the points. Okay.
Okay, sir.
Yes. So regarding accuracy, you almost mentioned all the points. And regarding supportiveness, rushing in time, it's against supportiveness because you don't care about his teaching. Clear?
Right, sir. Yeah. Okay.
Okay. Organized, you are organized. You divided the station into three parts, pre, during, and after. Also, introduction, very good. And you ask two questions. You explained the indication, contraindication, and other points as we mentioned earlier. So I think I can give you 8 marks. Okay.
Thank you, sir. Thank you
Yeah,
very much.
you are doing well. Thank you. Okay, Shwarya.
Yes, sir.
Okay, so the next station, it will be pleural tab. So tab here, you will insert the needle and take fluid sample from the pleural effusion. Okay,
Yes.
aspiration, it means you will do aspiration. So
Yes.
tab, you will just insert the needle and take fluid for lab. Okay,
Okay, sir.
and stop. After the lab results, you will understand, is it transudate or exudate? If exudate, you will aspirate. Clear
Oh,
now?
yes.
If the patient has symptoms, also you will aspirate, whatever it's exudate or transudate. Again, so you will aspirate from the beginning if the patient has symptoms, right?
Yes, sir.
If the patient has no symptoms, don't aspirate. You will take only tab. Okay. You will just take fluid sample, send it to the lab. If you find exudate, aspirate. Easy?
Yes, sir.
Okay. So you have 30 seconds, then 6 minutes.
Okay, sir.
So your task, you will teach the junior doctor about the procedure of pleural tab aspiration.
Okay, sir.
Give me 2 minutes, guys. 2 minutes.
Okay, sir.
Okay, you can start.
Hello, my name is Dr. Aishwarya, Emergency Medicine Registrar. Can you please confirm your name and level? I think you have something to discuss with me. Okay, so oh, fantastic. So you want to learn about the pleural tap, right? Okay. So how much do you know so far regarding the pleural tapping? Okay, no worries. I will start from the beginning. And anything specific you want to learn about it? Okay, fine. So do you have any patients? Okay, is the patient is safe? Okay, so I will set today class into some learning objectives. I will teach you the indications, contraindications, complications, and the precautions, the technique, instruments needed, and the how to assess the success of the procedure. Okay, and at the end, I will share you some website links and some videos to learn more about it. At any point of time, if you have any doubt, feel free to ask. Okay. So before doing the procedure, we need to approach the patient and ask about, take an ample history, okay, and address if any concern the patient have. And we need to explain these indications, contraindications, complications, the benefits of the procedure to the patient and take a consent from the patient, okay. Then next I will tell you what are the indications. Do you know what are the indications for pleural tapping? Good. Yes, pleural tapping we are doing for pleural effusion in diagnostic purpose as well as therapeutic purpose. Okay. And the contraindication is if we have any infection at the site of insertion, or the patient is having any bleeding disorders, or maybe the patient refuse this procedure. Okay. And the complications are the patient may have some pain, infection, bleeding, or sometimes we are giving anesthesia now, local anesthesia. So the patient can develop toxicity for that local anesthesia. And in some cases, the patient have internal organ injury as well. Okay, but we are very well trained in this procedure, so we can avoid any complications. And we should monitor the patient, and we need to sterilize the area before cleaning, before inserting the needle. And we need to apply we need to give painkillers, and need to give local anesthesia at the site of injection. And we can do the procedure in US guided as well, USC guided. Okay, and we need to get ready with a 20% intralipid solution at any point if the patient develop any toxicity to local anesthesia. And we need to tell the patient that to report if the patient having any signs of toxicity, like patient may feel circumoral numbness or metallic taste in tongue. Okay, then we need to take the consent as well. After that, we need to examine the patient. We need to look, listen, feel the chest and expose the chest. And we need to confirm the area of aspiration. Okay, because is it in right or left side? Okay. Then I will tell you what are the equipments needed for the pleural aspiration. It include syringe, large bore cannula, three-way tap, three-way stopcock, and the large. We need a syringe. We need two syringe and sterile drape, sterile gauze, and swab. Okay. Then you need to position the patient. The better position is sitting, and tell the patient to lean forward towards the table placed in front, and rest the hand on the table and lie down on the hand. Okay. Then about the technique, we need to wash our hands, wear the PPE, and arrange all the equipments nearby, and initially check the landmark. Do you know what is the landmark for pleural tapping? Okay, I'll tell you. So it is 7th to 9th rib space. It is from the midline of the axilla to the posterior axillary line. Okay, and mark it with a pen. And after that, we need to clean the area with aseptic solution, apply sterile drape, and then we need to infiltrate 1% lignocaine subcutaneously. And then insert the needle, which can be 16 to 18 gauge cannula. Okay, insert the cannula. The cannula must be attached to a 10 ml syringe. Okay, with some normal saline inside. And insert the needle while if it is in the correct position we are inserting, we will get some fluid will come into the syringe. At that time, initially we want to tapping only, so we need to send the sample for testing, so we can take some sample. Or otherwise, if the patient is having any symptoms, any severe shortness of breath like that, we can remove the fluid for therapeutic purpose as well. Okay, so be prepared for that. What is the purpose? And if it is a simple tapping only, we can take some fluid for the investigation, send it for the investigation, and wait for the report. If it is an exudate, we can do further aspiration later. Okay, otherwise you need to continue the aspiration. Do you know how to continue the aspiration? Okay, so I'll tell you. You need to remove the syringe from the cannula, and then remove the needle and the syringe from the cannula, then place a three-way connector on the cannula
Thank you.
end.
Your time done.
Yes, sir.
What do you think, guys? How many marks you will give Shwaria?
10.
Answer.
20.
Acceptable.
Eight, sir.
Did she finish the task?
No.
Why you will
No.
give 10?
She was
Three
so
marks.
concise and fluent.
Okay. So if she finish all the task, of course I will give her 10. She's very professional, calm, even she's rushing in time, but she's not showing us she's rushing. Okay, so try to concise your approach. No need to talk in details. Okay. Again, in the exam, it will be 8 minutes. We are pressing within 6 minutes. So I will give you 30 seconds.
Okay, sir. So I need to place the three-way coke into that. Into that, we can attach a 50 ml syringe and turn the tap and dispel the fluid into the atmosphere. We can draw 50 ml, then dispel into the atmosphere. Again, we can adjust with the three-way coke. And you can continue until the patient cough or 1.5 liters of fluid you are aspirating. And after the end, you need to take a chest radiograph and you need to auscultate the patient for to know the success of the result. Okay, so what advice you need to give to the patient? You need to monitor the patient for at least 4 hours, and then you can plan for the discharge. And you need to advise the patient to come back
Thank
to
you.
the.
Okay, thank you.
Yes, sir.
Okay. So here, I think accuracy, you almost mentioned all the points in the checklist, and the supportiveness, you are doing well. You asked how much the patient, the actor know, and anything specific, and you set learning objectives, and you are explaining step by step, and you are checking understanding. Organization, you are organized, and also regarding the knowledge, you have no errors. I think you covered almost everything. So I will give you 8 marks, okay?
Thank you, sir.
Yeah, thank you. Yara?
Yes, sir.
Okay. So for patient of needle aspiration, the station of Navid, you should give two possibilities. If the patient improved, so you will observe and discharge. If the patient is not improving, you will do chest drain. Here in fluid aspiration, pleural effusion, if the patient for the first time, and he is improved, so you have to check the reason, and you will see if he needs admission or not. If the patient recurrent or he has chronic disease, so it depends on the vital signs and depends on the organs function, organs function, and then you will see if the patient for admission or discharge. Okay, next station, tachyarrhythmia. They can test your skills in defibrillator, how to turn on the monitor, the defibrillator I mean, and how to put the pads or paddles, okay? So they will give you defibrillator, and I think um, all emergency physicians, you have a defibrillator in your hospital, okay? So here your task to assess and manage the patient and how to use the defibrillator. So it's not um, teaching, it's not teaching, it's resuscitation, right?
Yes,
Yes,
sir.
sir.
But you will show or demonstrate how to use defibrillator. So they will give you the monitor. Maybe they will give you VT, and they can give you a live patient, I mean unstable VT, and and cardiac arrest as well. So you can change from synchronized to unsynchronized. Clear? Okay. And the battle,
Okay.
maybe they will give you pads or paddles. Okay. Maybe this one, so you will carry, or the other one you will attach. So
Okay.
whatever this one, you will put one on the apex,
Mm.
and the other one on the right side below the clavicle. Paddle
Okay.
or both of them the same location. Okay. You have 30 seconds, then 60 minutes.
Hello?
Yes, you can start.
Doctor, can you hear me?
Yes.
Because it says my internet connection is unstable, that's why I was asking. Okay. So hello, I'm Dr. Yara, the team leader for today. May I have your name and levels, please? Are you both ALS providers? Nurse A, would you please handle the airway? Nurse B, would you please handle the monitors? We've been asked to look at a patient who presented with palpitations. He's noted to be tachycardic on his ECG. He has history of cardiomyopathy and heart failure. Is the patient there? Okay, is the patient conscious?
The patient is conscious.
Okay, and the airway, is it patent?
Better.
Okay, let's put the patient on high flow oxygen, and we'll move on with our assessment. Is the trachea central? Expose the patient and connect all monitors. Is the trachea central?
Trachea central.
And the neck veins?
Normal. Neck veins congested.
Saturation.
Neck veins congested.
Okay. Okay, and the saturation?
9.4.
And the respiratory rate?
40.
Inspection of the chest?
Normal.
Palpation?
Palpation, normal expansion.
Percussion?
Resonant.
And auscultation?
Auscultation, bilateral basal crepitation.
Auscultation of heart sounds?
There's S4.
Okay, so team, the patient appears to be in heart failure. We'll move on and check his blood pressure before we move on with our management. What's the blood pressure of the patient?
Blood pressure is 120/80.
And the heart rate?
Heart rate, this one.
Okay, so I can see VTAC on the monitor. Let's put two wide bore cannulas in, since the patient has signs of heart failure, that means he's in unstable tachycardia. Let's prepare for synchronized DC shock. As the patient is conscious, we'll need to give him some conscious sedation, midazolam and fentanyl. Let's charge the DC and attach the pads.
How to turn on the monitor?
First, we'll flip the switch to defibrillator, and then we will choose our joules. 120. We'll start with 120 and press on the sync button, and then we'll attach the pads to the patient. One in the right second intercostal space, and the other one on the apex of the heart in the left fourth intercostal space on the left side. Is the patient sedated?
Yes.
Okay, let's give the patient the first shock, 120 joules synchronized, and then we'll move on, and then we'll continue our assessment of the patient before we check the monitor again. Okay, let's move on. Let's withdraw labs for hematology, biochemistry, cardiac enzymes, and let's call on the cardiologist. Moving on to D, the patient is sedated right now. What about the pupils?
Equal reactive.
What about the random blood sugar?
5.
Okay. And on exposure of the patient, is there any abnormalities? Is there any abnormalities? Okay. What's the temperature?
37.
Okay. Has the cardiologist arrived? Okay. Let's reassess our patient. Is the airway still patent?
Beta.
Okay. And saturation?
9.4.
Okay. What's the heart rate right now? The heart rate? Hello?
What is the heart rate, guys?
Still the same. Oh, okay. On this monitor?
Still the
Okay,
same.
sorry.
Rhythm is
172.
I thought you were going to show an ECG. Okay. So it's still showing ventricular tachycardia. Let's give the patient the second shock, 150 joules. Is the patient still sedated?
Yes.
Okay, synchronized 150 joules, shock given. What's the monitor showing right now? Okay, is the cardiologist here? Okay, let's give the patient the third DC shock, synchronized 170, and shock given is what's the monitor showing right now? Okay, so this patient is still in ventricular tachycardia after 3 shocks. Let's give the patient 300 amide.
Not responding now.
Look, listen, feel. Is there any signs of life?
No signs of life.
Okay, okay, team, the patient is in cardiac arrest. Let's start high quality CPR while we charge the defibrillator to 200 joules unsynchronized. And let's put the patient on back valve mask ventilation. Please call the other resuscitation team, and let's see if the cardiologist is here. Is the defibrillator charged? Okay, let's give the shock. Give the first shock. And what's the monitor showing right now? Okay, continue CPR for 2 minutes, and then we'll look at the rhythm again. 2 minutes passed. Okay, let's give the second shock, unsynchronized, 200 joules. Shock given, and what's the monitor showing right now? Let's give the third shock, 200 joules unsynchronized, and the monitor is still showing the same. Okay, so 3 shocks. We've given 3 shocks, and the patient still has no signs of life in between cycles. So now we'll give 300 amiodarone bolus over 10 minutes, while continuing chest compressions for 2 minutes, and we'll give adrenaline 1 milligram per 1 milligram. 2 minutes passed.
60 minutes
Uh,
past.
6 minutes passed. 6 minutes يعني 3 cycles. أنا مش عارفة sorry.
Not 2 minutes, 6 minutes. What?
6 minutes passed. I gave like 3 cycles, 3 shocks, everything.
Okay.
Hmm.
What do you think, guys? How many marks you would give Yara?
task has been not finished. 7 or 8.
Mashallah, you follow the general approach.
Regarding the task, it's not I mean it's not clear the end of this task. Okay. So in resuscitation, don't expect an end to any station. Clear?
Yes,
Okay.
sir.
For example, teaching arterial cannulation. The end of the task, it means the admission of the patient. This is the end. It's a logic. But the end of this task, it's not clear. That's why I can give her 10 marks.
Yes, sir.
Because maybe the examiner want to stop here, or maybe after roast, or maybe his testing skills of synchronized DC shocks and unsynchronized DC shocks, and she did both, right? Okay. So for me, she did very well. Accuracy, almost all the points mentioned. Supportiveness, she's explaining everything. It seems like she's professional and also calm, organized. Okay. Regarding the rate and the rhythm, no need to ask the examiner because already you will
Check
find
the
out.
monitor. Yeah.
You can say, I will check the heart rate and rhythm. It seems like VT, like that. Clear? Any signs
Okay.
of life? Yes, the patient has signs of life. So it's you can say unstable tachycardia or VT. Call adult resuscitation team and the cardiologist prepare for defibrillator, synchronized DC shock, and in the meantime, insert two IV access, extract the blood for blah 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 blah. Okay. Don't give failure because the patient has signs of heart failure. Okay. But if he has
Yes.
shock, if he has shock, so you can give 250 ml only because it's
Yeah.
cardiac shock. But I give you
Okay.
the blood pressure normal. Okay.
Yeah.
You did not ask about CRT and
Yeah,
peripheral.
I forgot. I rushed.
Be
Yeah.
because when I show you bilateral basal crepitation, I felt you want to give DC shock without checking circulation.
Mm.
So
Yeah.
once you find the patient has signs of heart failure, ignore breathing because no intervention in breathing. Okay, you will go to
Mm.
see circulation and do assessment, complete assessment. Okay, don't be in a hurry to do intervention. So assessment, then finding, then call, then intervention. So you will ask about blood pressure, CRT, peripheral pulses, and heart rate and rhythm, not heart rate only, heart rate and rhythm.
Okay.
If you find
Okay.
the rhythm is VT, so you can verbalize. It seems like unstable tachycardia, VT. Then you finish the finding. Go for call. Call, blah, 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 blah. Then don't be in a hurry to give shock. The priority,
Mm.
insert to IV access and extract the blood, blah, blah, blah. But I want you to mention both in the same time. So the priority to prepare defibrillator, okay?
Okay. Mm.
But how you will give the patient DC shock without sedation? Not logic. Clear now?
Yeah.
So
Yes.
the priority DC shock, also you have to insert the IV access first. So to be professional, you can say like that. Please prepare defibrillator, attach pads on blah blah
Mm.
blah blah. In the
Okay.
meantime, insert two IV access, extract the blood for blah 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 blah, and no need to give fluid because no indication here. And
Yeah.
then you will give the patient sedation. You mention sedation, but without mentioning the dose. Okay.
Yes. Mm.
This conscious sedation or rapid sequence induction, guys?
Conscious sedation.
Conscious sedation.
Conscious sedation. Excellent.
Just
So you will give half dose. So if you will
Okay.
give propofol, it will be 1 milligram per
Okay.
kilogram. In last session, we are doing rapid sequence induction. So propofol 2 milligram. The here different. Okay. So
Okay.
fentanyl and propofol, or you can give midazolam only. No problem. Okay.
Okay.
If you want
Mm.
to give midazolam and fentanyl. Okay. So regarding this station, I think you covered almost everything. But before checking the patient in unsynchronized, you will give the unsynchronized DC shock, the first one, okay?
Mm.
And
Okay.
then you will go for high quality CPR. Before doing high quality CPR, I said look, listen, and feel no signs of life. So the first action, you will mention
Let's
the
give the shock.
findings. The finding
Okay.
means the patient in cardiac arrest. Then call adult
Okay.
resuscitation team. Then intervention. Intervention here, it means high quality CPR. 30
Mm.
ventilation to ventilation.
Mm.
And you will give the patient unsynchronized DC shock 200 joule. Good.
Okay.
Then you will verbalize for H40s. I will consider for H40s. The most likely problem, um, it's a heart problem. Clear? But I
Okay.
cannot say thrombosis. I cannot say
Mm.
thrombosis. So you can say heart problem, maybe hypoxia or hypovolemia. But I cannot say thrombosis here because the patient has no history. You did not
Okay.
verbalize the 4H40s. Okay.
Okay.
Then 2 minutes passed. Yes, check stop switch, check the rhythm and signs of life. Okay.
Okay.
If the examiner is silent, it means no signs of life. Because if you
Okay.
want to say the patient has signs of life, he will mention. Okay. Well done. I think you covered almost everything. Thank you.
Okay, thank you.
Welcome. Amira, sorry,
Yep.
next one.
Dr. Hani, may I ask one question in this case?
Yes,
That after the synchronized,
yes,
shock, do we need to complete the D, E, and then come to the A again, then give the second synchronized shock, or we can stay there?
yes, excellent. So here, the problem where in C, the first C, first circulation, right, in primary assessment. Okay, so after you give the patient sedation, after you give synchronized DC shock, then go for D. Don't check the rhythm now. Clear?
Yes, sir, clear.
You will go for D, disability, then exposure, then you will go for A, for B, then second C, you will check the heart rate and rhythm again. Okay? Okay.
So for each synchronized shock, we will do the same, yani, A, B, C, D, we'll complete it.
For synchronized DC shock, you will give in C and then go for D, E, A, B, and check again in C. But unsynchronized the patient in cardiac arrest. So you will check signs of life every 2 minutes. Okay?
Then after CPR.
Yes.
Thank you.
Okay.
And
So
just had one question, Dr. Henny. For yes, for this point, because I was planning to ask the same question, and um, the patient here is unstable. He has sign of heart failure,
you
and
mean
if
unstable.
there is
You mean unstable.
unstable, yes, he's unstable. So
Okay.
do you think, yani, we need to move to D1 and we don't resolve the problem in C here?
Why
Wha-
you
wha-
will
wha-
go for D? No, give action, give intervention in C, the first C. And after synchronize this shock, go for D and then for E.
No, here the question was about there was first synchronized shock, then what not successful, the second one, the third. Then I think yani, she give
H,
amiodarone,
H,
then go move to D at that point
HDC,
because 10 minutes.
please, doctor.
Yes.
HDC shock synchronized, you will go for D, for E, and after that A, B, C. Okay, and then in the second C, you will check if the patient has the same problem or not. Okay, I told her in the third DC shock, the patient is not responding. That's why she asked, look, listen, and feel in signs of life.
Mm.
No need to give amiodarone. I said the patient is not responding. If the patient is still the same, she can go for amiodarone after the third
Yes, yes.
night DC shock. Clear?
Okay, thank you.
Next one.
Simi Kashif.
Okay, Kashif. Okay. Here they can test your skills in basing, transcutaneous basing, okay? So they will ask you to turn on the basing. So you can put in basing mode. Number one, turn on. Number two, basing mode. Some machine you will find demand and fixed mode. So you will put on demand, okay? Number three, number three, the okay. So here you can choose the milliampere and the heart rate. By default, once you turn on the monitor, you find 70 and the milliampere 0. Okay. Maximum 100, 200. Maximum 200. So from 0, you can upgrade. Okay. Clear, Kashif?
Yes, sir.
Okay. So you have 30 seconds and then 6 minutes.
Good evening. I am Dr. Kashif, ED Registrar. May I confirm your name and levels, please? Nice to meet you. Are you both ALS provider? Nurse A, kindly take care of the airway and kindly prepare the airway equipments. Nurse B, kindly take care of the circulation and prepare the circulatory equipments. We are expected to receive a 63 years old male who collapsed in the street with syncopal episode. And kindly wash your hands, wear PPE, and kindly inform the adult resuscitation team. Did the patient arrive? Any endorsement from the ambulance crew? Is the patient conscious?
The patient is conscious.
Is airway patent?
Patent.
Kindly apply high flow oxygen via non-rebel mask. I will go proceed for the breathing. What is the oxygen saturation?
94.
And what is the respiratory rate?
RR is 40.
Is trachea central?
Trachea central.
Are neck veins normal?
Normal.
Chest on inspection?
Normal.
Palpation?
Normal.
Percussion of chest?
Normal.
Auscultation of lungs and heart?
Normal.
Okay. And I will proceed for the circulation. What is blood pressure?
Blood pressure 120/80.
And what is capillary refill time?
CRT normal.
What about peripheral pulses?
Normal.
And what about heart rate and rhythm? So, guys, this patient is having a bradycardia, and his ECG shows the complete heart block. Kindly inform the adult resuscitation team. Kindly call cardiology, and uh, as this patient has syncopal episode, this is high risk adverse effect for the bradycardia. Kindly nurse B kindly pass to IV lines and take blood for CBC, urean electrolytes, blood gases, and cardiac enzymes, and kindly give atropine 0.5 milligram IV, and we can repeat it after every 5 minutes till a total dose of 3 milligram. And I will now proceed for the disability. What is the GCS of the patient?
15.
Okay. And what about the pupils bilateral equally reactive?
Equal.
And what about the peripheral pulse, any signs of lateralization?
Normal.
Okay. And what about the random blood sugar?
5.
Okay. And what kindly expose the patient, and we have already attached the monitors also. And what is the temperature of the patient?
37.
And what is the any other abnormalities found on inspection of the body? Okay. I want to endorse this patient to the adult resuscitation team and ICU team. Is anyone arrived? Meanwhile, I will reassess this patient. What is the airways? Is the patient conscious?
The patient conscious.
Is the airway patent?
Patent.
What is oxygen saturation?
94.
And what is the blood pressure?
Normal.
And what about heart rate rhythm? Same heart rate rhythm. And 5 minutes apart, kindly repeat the second dose of atropine, and I will proceed further. And what about GCS?
Same.
Okay. And temperature is normal.
Yes.
I will again reassess the patient. And what about oxygen saturation?
Same.
And what about blood pressure,
Same.
heart rate, rhythm? Okay, we have given the total 3 milligram of atropine. We kindly prepare for the pacing and kindly sedate the patient. And I will start the pacing mode. I will select the heart rate 70, and I will select current 30 milliampere. Kindly, I am going to do pacing. Pacing done. And what is the heart rate? What is the rhythm now? Is there any electrical capture? So there is no electrical capture. Kindly increase the current to the 40 milliampere and do the pacing again. And what is the is there any electrical capture? Yes. No, there is no electrical capture. Kindly increase the current to 50 milliampere. I will do pacing again. And still there is no electrical capture. And I will increase the current of 60 milliampere. I will do pacing again. Still there is no electrical capture. I will increase the current to 70 milliampere and see the rhythm. Still rhythm is the same. There is no electrical capture. I will increase the current to 80 milliampere and I will do electrical capture. There is no electrical capture as yet. I will increase current to 90 milliampere and any change in rhythm. Still there is no change in rhythm. I will increase the current to 100 milliamperes. Any change in rhythm. Still there is no electrical capture. I will increase current to 110 milliamperes. Is there any change in rhythm? There is no change in rhythm as yet. And no electrical capture. I will increase current to 120 milliamperes. Is there any change in rhythm? Still there is no electrical capture. I will increase current to 130 milliamperes. Is there any change in rhythm? Still there is no electrical capture. I will increase current to 140 milliampere. Is there any change in rhythm? Still there is no electrical capture. I will increase current to 150 milliampere. Is there any change in rhythm? Still there is no change in rhythm. Okay, so guys, we have there is electrical capture. I will look for the pulse, blood pressure, and conscious status. Is there a mechanical capture present? And so guys, we have successfully resuscitated this patient, and we are waiting for the cardiology and adult resuscitation team to arrive and hand over this patient to them. Is any blood test ready?
Thank you. Thank you.
And anything else we can do?
Thank you.
We can
That's it.
repeat one ECG and X-ray for this patient.
Can you hear me?
Yes, sir.
Thank you. Your time done.
Thank you. Thank you.
Please, if your time done, stop. Okay. What do you think, guys? How many marks you'll give Kashif?
10, sir. 9 to 10, sir. Good. You did mashallah well.
Okay. So you can still increase 10 by 10, okay, until you reach the maximum, if no electrical capture. If you have electrical capture, then you can increase only 10 to 15, okay? For example, the patient here, he got electrical capture on 60, for example. So you will increase to 80 and stop. Clear, Kashif?
Yes, sir.
So the milliampere current, which cause electrical capture, for example, 60, increase 15 or 20 above. Okay? Okay. Here, when I show you this one, so you said no electrical capture. Is this not good finding? I mean about verbalization of the findings. You can say the
Yes.
patient has pacing rhythm. Clear now?
Yes, sir.
You did not mention that. You should say
Yes, sir.
the patient has pacing rhythm, but no
Electrical
Electrical.
capture.
electrical capture. Clear now?
Yes.
Because if you say no electrical capture, maybe he has no pacing rhythm also. Clear? I will
Yes, sir.
not check electrical capture at the in the beginning. No. Number one, you check pacing rhythm. Why? Pacing rhythm, it means you are connecting the pads correctly and the machine is working correctly. Clear?
Yes, sir.
If I see basing, this one, this one, this one, this one, it means everything is correct. Okay? Okay. So how to know electrical capture? So each two basing rhythm, you should find waves between. So here waves, but here no. Here waves, but here no. You should find in all leads. Okay. I think you covered almost everything and you did well. Um, Try to give up to 3 milligram in the beginning. Also, if your task about pacing, you should attach the pacing early. Clear?
Yes, sir.
So if they said demonstrate transcutaneous pacing, then once you give the first dose of atropine, you should turn on the pacing. Clear?
Yes, sir.
Because even if your time done, already you attach the pads and you turn on the monitor, you put on the pacing, you choose pacing mode, okay? And then don't choose the milliampere now. Just explain. You can say by default, the heart rate is 70 and the milliampere is 0. And don't do anything. You can go for atropine, atropine, atropine. And if not responding, you can go for adrenaline or isoprenaline. Then transcutaneous pacing. Okay, you did well, but I'm optimizing your approach, so I will give you 8 marks. Thank you.
Yes, sir.
Sir, can you repeat that increasing the current 2010? I didn't understand that.
You can listen to the recording.
Okay, sir.
Next one, I think Muhammad.
Yes, sir.
Okay, ventilator, it's not important, but as we mentioned before, we have to practice everything because the Royal College can give you any station, even rare, even not coming before. Okay, so ventilator here, they will test your skills in non-invasive ventilator. Okay, so if they give you the size of the mouth, so you have small, medium, and large. Please fix your mic, Mohammed, and you can size also from the level of the eye to below the lip. So the top of the nose till below the mouth. If they give you the mask, you can mention the parts only. Then the machine here almost is the same in all ventilators. Okay, so you can choose the mode. You have many modes. You can just verbalize each mode and the name. And also you have tidal volume, respiratory rate. Very important to talk about tidal volume and RR and FiO2. Even you did not comment on other points, it's not a big issue. So the most important in any machine, tidal volume 6 to 8, body weight, RR 12, and you can titrate up to 20. The minute ventilation, tidal volume multiply RR. That's not important. Just if you have time, you can mention what does this mean and IE ratio. So You will find here CPAP, BiPAP, IPPV, and some here the 100% oxygen. This one FiO2, this one tidal volume, this one frequency or RR, this one Vmax. Okay. Okay. Muhammad,
Yes, sir.
so your task to teach the junior doctor about the ventilator. Okay. So you will discuss about indication, contraindication, and complication, um, and then you will talk about the parts, how to size, and then the machine. You will mention the points. Okay.
Okay, sir.
You have 30 seconds and 6 minutes.
Okay. May I start, sir?
Raise your voice, please.
May I start, sir?
Okay.
Okay. Hello, my name is Dr. Tahir. I am the registrar. May I know your name and level, please? I think you have want to learn about the ventilator machine. Am I correct? Okay. How far do you know about the ventilator machine? Knife? Is there anything specific that you want to learn about the knife? Okay. Today I will teach you about how to use the knife and how to use a mask and how to size the mask and parts of the knife face mask and also what about the modes of the ventilation. Okay, so I will teach you about the indications and the contraindications and complications and how to avoid the complication, preparation and technique and how to post technique management and the advice and the documentation. Okay. So the indications of the knife is it is used in the most of the time it is a CPAP and BiPAP. The CPAP is used in type 1 respiratory failure when patient has a low saturation, and BiPAP is used for the type 2 respiratory failure when the patient has the low PO2 less than 8 kilopascal and as well as the PCO2 greater than 6. The contraindications of this knife is patient refusal and trauma, and the relative contraindications are like vomiting, reduced level of consciousness. Are you with me? Okay. The complications can be the ulcer, aspiration, and it could be hypotension. Okay. Uh, Now I will teach you how to fit the mask. It should be from the lateral canthus eye of the eye to just below the chin to make sure that is the proper seal made around your patient mouth. And now I will explain the parts of the face mask. The first part is the chin cup for stability and comfort, and the second part is the metro seal between mask, tube, and skin. Then there is the adjustment point for anatomical position. Then there is swivel elbow for connecting for the CPAP and the BiPAP. Then there is a deep sealing flange on the nose bridge, and then there is a low dead space mask that will help in CO2 clearance. Okay, are you understand? Okay, now I will also teach you about the size of the mask. It was small, medium, and the large. And I already told you about how to size and fix the mask. And it will be small, medium, and large according to the patient body build. Now I will tell you about the modes of the ventilation. It could be the BiPAP, CPAP, and IPPV and SMV. But most of the time we use the CPAP and the BiPAP mode, and we look for the tidal volume. That could be the 6 to 8 ml per kg according to the body weight, and then respiratory rate should be the 12 to 20 breath per minute, and the IE ratio should be 1:4, and FI2 should be maintained about in normal patient above 94%, and in COPD patient it should be above in between 88 to 92%. Then BiPAP, we can use the IPAP up to 10 centimeter and the EPAP up to 5 centimeter. And when we attach the patient on the BiPAP, first of all, we will do the ABGs at the start at the room air, then after the 1 hour, and after that, we will check the success of the knife. Is patient is responding to the knife or not, and we can further we can adjust the settings according to that. Like we can increase the ventilator volume and the Pmax, as well as we can adjust FiO2 according to the saturation of the patient. Have you understand now? Have you understand the procedure and the parts of the knife? Do you have any question? Okay, let me recap the indications and the contraindications and the indications.
Regarding the ABG, when to start the ABG and when to repeat the ABG.
It should be at the start at the room air at 0 minute, and then after the 1 hour.
Okay.
After attachment of the BiPAP or knife.
Okay.
Okay. So, do you want me to explain more or anything else? Do you want to learn?
Okay, thank you. Thank you, Muhammad. Your time almost done.
Okay.
What do you think, guys? How many marks for Muhammad?
Mashallah, sir, he did well.
MashaAllah, 10, sir.
Okay, well done. So, you should discuss about the three parts of the station before, during, and after. So before here, it means you should talk about indication, contraindication, complication, how to avoid the complications, and then during. During here, it means preparation. So prepare the patient. The patient should be in a semi-sitting position, and also you will fix the mask. You will talk about the parts of the mask and how to size. Okay. You choose the suitable size for the patient according to the size measure, and then you will go for preparation of the doctor. Here for you, it's not about washing hands will be. It's not very important here because no infection here. It's not important, not invasive, I mean, because it's non-invasive. So here you will go for the preparation of the monitor. So preparation of the patient, preparation of equipment, it means monitor and the mask, okay? So you will go for the machine as we discussed earlier. After that, after you connect and after setting all the buttons, then we will go for after. After here, it means observation of the patient, vital signs, observation of the SpO2, HCO2, and also you can do ABG after 1 hour and then every 4 hours if the patient is improving. And you can do ABG after any change in the machine. If the patient is not improving, and he has respiratory failure type 2, despite maximum medical treatment and non-invasive ventilation, then you can go for invasive ventilation. It means endotracheal tube. Okay, so I will give you 8 marks, Muhammad. Thank you. Shayati?
Yes, Dr.
Yes.
Hani, good evening.
Yes. Okay, so acidic drainage, this station not important. So
Okay.
same approach, okay?
Yes.
You will divide the station into 3 parts. The most important, you know, the landmarks. And regarding aspiration, so you will aspirate and put in bags. How many bags? So until the patient symptoms improve, okay?
Yes.
You have to correct the blood pressure by fluids and albumin also, okay?
Hmm.
Yes. You have 30 seconds and 6 minutes.
I will start.
Okay.
Okay. Hello, I am Dr. Chaiti, Emergency Registrar. May I know your name and level, please? Nice to meet you, Dr. Sami. I believe you have something to discuss with me. Okay, you want to learn about ascitic drainage? Okay, it's an important topic and practical skill. How much do you know so far? Anything specific you want to learn? Okay, great. So I will set you a learning objective that will include indication, contraindication, complication, how to prevent the complication, assessment of success. After we finish our session, I'll give you good videos and learning materials so that we can keep ourselves updated. While the session, if you have anything to discuss, please stop me and you are most welcome to ask. So now let me tell you the indication. Now, indication of ascitic tapping is the patient who is coming with a abdominal distension with a history of cirrhosis of liver. You are having a confirmation of an ascites. You need to drain that. That's the indication. What is a contraindication? If that site of insertion is a infection or the patient is having a bleeding disorder, that's a contraindication. Now, what is a complication? Complication is the patient can have a bleeding or patient can have an internal organ injury. So how do we prevent that? By a well-trained professional, and we can do by ultrasound guide. Now, after all this, when you have a patient, you need to explain the procedure to the patient. So we have the techniques of how to do it. We have to prepare ourselves and then positioning the patient. Okay. And before all, we have to examine the patient, confirm the ascites by doing a ascitic shifting dullness, then connect to a monitor, put IV cannula because the patient will be with IV fluid and also mostly albumin. Now let's begin with the technique. So how do we technique? We prepare ourselves by wearing a personal protective equipments, gloves. Then we prepare by taking a trolley, sterile drip, syringe, local anesthesia, intralipid in case if the patient develop a local anesthetic toxicity, then bag, then 50 ml syringes. Okay. Now, what is the landmark? Landmark is 2 to 3 centimeter below the umbilicus in the midline. And if it is a lateral, so it will be 2 to 4 centimeters supromedial to anterior superior iliac spine. Okay. Now, once you identify the landmark, clean that area, and then you have to drape it with a sterile. After putting a drape, you take as 1% of lidocaine. Okay. And then you have to take with the 2 syringe, one superficially and dip, you will anesthetize that area. After anesthetizing that area, what you will do, you will take a needle with a, and you will insert the needle, okay? Needle with, after inserting the needle, you will aspirate. But first with the 10 ml syringe, you will aspirate to confirm that position of the fluid. Once you aspirate the fluid, you can change the 10 ml to 50 ml syringe and keep on aspirating. Okay, plus please keep on watch on the monitor for the patient can have a hypertension. So always keep that patient is on IV fluid and albumin, as I told you. Now, if the patient have a large ascites, you can keep on draining on the bag, a collection container, okay? Or you can put with a collecting tube drain and connect to the collection container. Now, this tap which you have drained, you have to send this for a diagnostic purpose. And what you have done, this ascitic tapping is also therapeutic. Now, how do you know the success of your procedure? You have to check the monitor and the clinical finding, how the abdominal distension has reduced for the patient. Patient is feeling comfortable. The monitor is showing the normal vital signs of the patient. Since you have done this procedure, the patient has to be in the hospital for either, depending on the condition of the patient needs an admission. For whatever I have told you till now, did you understand? Do you have any further question to ask me? Okay, so we can do a recapitulation of what we have done, and I will be happy if you can explain me the procedure very well.
So how many bags we can drain?
We can drain a minimum of two to three bags. You mean bags, right?
Okay.
So we are draining 50 ml, and we can drain the 50 ml, and we can keep on draining the 50 ml and then put in the container. Hello.
Yes, so if the patient has hypotension,
Hypotension, then all we have put on the fluid, which I have already said, but hypotension, we have to hold the procedure. We cannot continue.
okay, so what you will do?
We will first vitally, we will make the patient stable, start on IV fluid, do albumin. And then after doing the procedure, we have to put a sterile gauze and close the site of the.
Okay, thank
Then
you.
okay.
Okay, your time almost done. 10 seconds. Okay. How many marks, guys, you will give Shati?
9.
Okay, well done. So here you will insert in the landmarks, you will insert cannula. Okay. After that, you can connect it to a three-way tubing and to syringe, and you can connect it to bag. And by three-way, you can aspirate from the patient, then it changes the three-way to the bag. So you can convert from patient to the bag, from patient to the bag. Okay.
Yes.
Here, this is the three-way. Okay. So I think you almost mentioned everything, but here no need to mention about the 50 ml. Just you will by three-way you can convert from patient to the bag, from patient to bag. Okay. So you have to observe the patient, check the vital signs. Also, you will do ultrasound before and after. Okay. And this patient, if new, you will send for lab and you search for the reason. And if old or chronic, so according to organ functions, you will check if he needs any admission. Okay, so I will give you 8 marks.
Thank you, Dr.
Welcome. Muhammad Imran.
Sir, we have to explain
Yes,
the
sir.
Z-line technique.
Sorry?
Z-line technique.
Yes,
technique.
here regarding details, sometimes it's not required because, you know, in teaching, basics important than details. Did you get my point?
Yes, sir.
So here,
So just we verbalize.
yes. So if junior doctor you will give more details if junior nurse, you will give less details. Clear? So if you will teach nurse, if they mention nurse in the scenario, it means don't give advanced
Okay.
information. Clear, guys, this point?
Yes, sir.
Okay.
Yes,
So
sir.
if you will
Yes.
teach a patient, if you will teach a patient, don't give him much information because he is patient, not in medical field. Nurse, you will give less information. If junior doctor, you will give more information. If, for example, if you are consultant in final OSCE and they will ask you to discuss with ST4, so it's a different, okay, and so on. So anyway, you can just mention the steps. So like the position of the patient. Also, you will do cleaning, local anesthesia, drape, cover the patient, expose the landmarks, and then you will insert a small needle for local anesthesia, large needle for aspiration, and you will use Z technique. Okay. So if you mention Z technique without explanation, it's not a big issue. But if the actor asks you what is that technique, it means the Royal College want to test your skills in this point. Clear?
Clear.
If they ask you to explain, explain. But if they did not ask you, no problem. If you have time, if you finish the station and you still have time, no problem. You can tell him about the technique. Okay. So I think all of you familiar with the technique.
Yes.
Just one question, Dr. Hani. For this
Yes.
patient, how long should be monitoring after the procedure?
Yes, any patient with invasive procedure, you have to monitor before and after. Clear?
Yes, yes.
Any invasive procedure, because it's invasive. Maybe the patient will go through shock or any arrhythmia or anything. Okay. Next one, Muhammad Amran.
Yes, sir.
Lumbar puncture, it's not important. But again, we have to practice everything. You have 30 seconds and then 6 minutes. This patient or this station, the same approach. You will divide the station into 3 parts, before, during, and after. I'm talking now about the during. So the equipment, yes. So here you have spinal needle and you have a stylet, and this is a spinal needle, like that. Okay. So if you are inserting, you should insert the stylet and the spinal needle. Don't remove. Okay. Then here, to decrease the risk of headache or post-lumbar puncture headache, you should choose which needle?
Pencil tip, white care.
Yes, this one. This one will cause a small rupture, but this one large rupture. So why the patient has headache? Because of large rupture, because maybe CSF is leaking here, but here unlikely. That's why you should choose pencil point. The patient in lying position, okay, but it's not very important. The most important, the needle and the size of the needle, small needle. So if you use pencil point needle but large, no benefit. So it should be pencil point, and the needle size should be small also. Clear?
Yes, sir.
Okay. So regarding the size, um, I mean the landmarks should be lumbar 3, lumbar 4, or lumbar 4, lumbar 5. After inserting, you will see dripping of the CSF fluid, and then you will connect it to what?
Manometer, sir.
It will be in the same level.
Yes, sir.
Okay. So this is the insertion. The patient will be lying in left lateral position. Okay. Um, Here you will check the pressure first. How much is the normal pressure, guys?
10 to 15.
10 to 20.
Yes, it's seems like that. It's different from source to source, but it's about 12 to 18, or you can say 10 to 20, no problem. It's different from source to source. So if the pressure is low, don't aspirate. Clear?
Yes, sir.
If the pressure is low, because you will decrease more. But if the pressure is high, you have to aspirate to make it normal. If the pressure is normal, you can aspirate also. So you will aspirate how many drops? 8
8
drops.
drops.
8, 8, 8, 8, like that. So 5 times. Okay. 5 tubes for glucose, cell count, protein, bramstein, xanthochromia. So this one you will cover um, with what?
Subarachnoid hemorrhage.
You will cover with what? The tube. Huh? Yes, because it's affected by light. Okay, you have 30 seconds and then 60 minutes. So your task, teach the junior doctor about lumbar puncture. Okay, you should be familiar with the layers first. So here, which layer you will puncture?
Skin, superficial fascia, supraspinatus ligament, interspinous ligament, ligamentum flavum, then the durometer, then the epidural space, and the subarachnoid.
Yeah. So you have to mention the layers first. 1, 2, 3, 4, 5, like that. Okay. And you
Okay.
have to mention the direction.
Okay, towards the umbilicus, 10 to 15
Lumbar
degrees.
4, lumbar 5, or
Yes,
lumbar
sir.
5 is 1, and the direction towards the umbilicus. Okay.
Yeah.
So what is your target?
Subarachnoid space.
Yes. Excellent. Okay. So you have 30 seconds and 60 minutes.
Hi, good morning. I am Dr. Azim Imran. May I confirm your name and level of competence, please? I believe that you are here to discuss something with me. Yes. How do you know so far about the lumbar puncture? It really a fantastic and very much interesting topic to learn. Today, I will teach you about the indication, contraindication, complication, how to prevent the complication, and the post-procedure advice and the management. Is it okay? So to proceed with the, first of all, we have to examine the patient, and then we will check the vitals, and then we will do the technique. We will learn the technique. So regarding the indication, we do the lumbar puncture to obtain the CSF for investigation and measure the CSF pressure. Moreover, we do the lumbar puncture for Guillain-Barré syndrome, and we do the spinal anesthesia through the lumbar puncture. And in certain condition, we deliver the chemotherapeutic agents through the spinal needle. And regarding the contraindication of the lumbar puncture, is there if there is a cellulitis or the infection over the insertion site. This is the one contraindication. The other is coagulopathy, and the third is the patient is reduced GCS, and there is, if the increase intracranial pressure, then we don't do the lumbar puncture. Are you getting me? Okay. Now I will teach you what are the complications of the lumbar puncture. It is the post-procedure headache along with the nausea and vomiting. The other is the infection. Either this is a meningitis or epidural abscess. The third is hematoma. and damage to the spinal cord or spinal nerve. Are you with me? Is it clear? If anything is in doubt, you can stop me. Okay. Now I will teach you what is the procedure and the technique. Regarding the procedure, we divide it into the pre-procedure, during the procedure, and post-procedure. For the pre-procedure, we have to take the consent, prepare the patient, prepare the doctor as well as we have to look for the prepare the equipment, and we have to measure the landmark. For the preparation of the doctor, we wash our hands and wear the PPE. For the preparation of the patient, we clean the area with the chlorhexidine or antiseptic solution and drape the area, and regarding the position, we put the patient in the lateral decubitus position with the knee over the chest and add the back to the side of the table. Then for the preparation of the equipment, we need the sterile swab, LP needle, local anesthesia, and manometer, along with the sterile trap and sterile gauze and the containers, along with the procedure tree. So regarding the landmark, it is we do the lumbar puncture at the level of the posterior iliac crest. That is the level of L4 or L5. Sometimes we do the lumbar puncture at the site of L3 and L4 space. So first of all, we do the put the patient in the lateral decubitus position and identify the landmark. That is the L4 and L5. Then we will give the local anesthesia to the patient. And before the local anesthesia, we have to keep in mind the local anesthesia toxicity, and we ask about the patient, warn the patient about the local anesthesia toxicity symptom, that is the circumoral numbness and the metallic taste. If the patient develops, then we have to, before in hand, the interlippers to treat with the local anesthesia toxicity. So first of all, we will clean the area, and we will do the local anesthesia to the skin and the subcutaneous tissue at the 10 to 15 degree angle, and then we remove this needle of the local anesthesia, and we insert the lumbar puncture needle 10 to 15 degree and towards the umbilicus, and we pass through the skin, subcutaneous tissue, and then interspinous ligament, supraspinatus ligament, ligamentum flavum, and then the dura mater, and we reach the subarachnoid space. So while passing through this from the back to the subarachnoid space, we feel the two pop. One pop at the ligamentum flavum, the second pop at the dura mater. When we remove the stellate from the lumbar puncture needle, the CSF will start draining out, and then we attach the lumbar puncture with the manometer, and we measure the opening pressure. Usually the opening pressure is 10 to 20 centimeter of water. We keep the manometer and the needle, LP needle at the same time. Then we collect the CSF in 5 different tubes. One tube for the glucose, and the other tube for the protein, and the other for cell count, the other for gram staining, and the other for the chromia. In each tube, we collect 8 drops of the CSF. Then we after doing this, we replace the stellate into the LP needle, and then we remove the needle along with this stellate. After doing the procedure, we keep the patient in the lateral decubitus position, and we measure the vitals again of the patient. Then, to avoid the complication of the spinal headache, we use the needle that is white care needle or pencil type needle, and with small size of the needle, and we give the fluid before passing the before doing the procedure. And after the procedure, we give the printed leaflet to the patient to do
Thank
not to
you.
spread.
Your time done. Thank you. Okay, what do you think, guys? How many marks you will give, Imran?
10 to 10.
20.
Excellent.
Okay.
Nice, sir. 10 to 10.
Dr.
Okay.
Nubi, there are a lot of improvements still.
Yeah, you are doing well. Excellent, mashallah.
Thank
Okay,
you, sir.
you are working on organization. You are trying to make everything organized. If you are organized, of course, you will understand and you will be professional, you will be calm, you will be confident, and you will save time also. Okay, well done. So accuracy, I think you almost mentioned all the points. Organization, organized. Skillfulness, you are very fluent. And supportiveness, you are pausing. Um, you are not fast. You are trying to check understanding. So 10 marks, and I'm happy for this station. Thank you.
Thank you very much, sir. This is the first time you give me 10 marks.
You are doing well.
Thank you.
Okay, next one, May.
Yes, doctor.
Yes. The next station. Yes, very important and very, very common. You should practice this station and memorize it like your name. Okay. Diane,
I agree.
how are you?
I'm okay, sir.
Yeah. So procedural sedation, it can be teach the junior doctor, and also it could be um, take consent from the patient. Okay. So we will do both stations, one for teaching and one to take consent. May, you will do teaching, and Diane, you will take consent from the patient, okay?
No problem, sir.
So for May, we have teaching here. For Diane, you you can cancel teaching. You will not find teaching in the right chart, okay? So
No problem.
Diane, your task, take consent from the patient regarding procedural sedation. Okay?
No problem.
Okay. So here in procedural sedation, you will divide the station into three parts: before, during, and after. In teaching, you will follow the general approach of teaching. I am blah 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 blah. May I know your name and the level? And then you will go for I believe you have something to discuss with me regarding procedural sedation. Nice topic. How much do you know so far? Anything specific? The same approach. Okay. I will set learning objectives for you. I will teach you procedural sedation, the types of sedation, and I will teach you about indication, contraindication, blah 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 blah. Preparation, technique, and the same as all procedures. Okay. Then the indication, you will do what? DC shock, synchronized. You will do sutures. You will do reduction. Okay, like that. Contraindication if the patient needs general anesthesia. Okay. If the patient also has um, agitation or anything like that. Okay. If the patient has difficult airway. So, how to know the contraindication? You have ample history, you have lemon assessment. Do you remember in SBA exam or intermediate?
Yes,
So,
both.
yes.
Yes.
So
Yes,
you
sir.
have ample history, you have lemon assessment, you have ASA classification. Why we are doing ample history? To know if the patient has contraindication. Lemon assessment, because at any time, even conscious sedation, it's not general anesthesia. For example, propofol for conscious sedation 1 milligram. For intubation, you will give 2 milligram because general anesthesia. Sometimes you will give 1 milligram only, the patient will go in general anesthesia. Even 1 milligram, yes. Sometimes patients they are sensitive. to medications. So anyway, at any time the patient will go in general anesthesia, he needs intubation. If the patient has difficulty airway and already he is in general anesthesia, so it will be difficulty intubation and the patient might die. Okay, so I mean, you have to assess ample history. You will take data, history, and lemon assessment. You will do assessment. It means examination. After that, ASA classification. ASA here, it's history also. Okay, so in the station for May, you will just verbalize. May, are you with me?
Yes, doctor.
Yes. So you will say for contraindication, you have to assess ample history, do lemon assessment, and check ASA classification, but don't mention anything else. Clear?
Okay.
For Diane, you will do so. You will ask the patient about ample history, and you will do lemon assessment. So you can say, I will check. I lemon, it means Lemon, right?
That's it.
Lemon. So you will just pretend the patient in front of you and just pretend. No need to examine. Okay. For L means look externally. Just verbalize. I will look externally for any sign of difficult airway. And then E. What is E?
Evaluate series 3
Excellent. So I will evaluate 332 by fingers. Thank you. Like that, acting. This exam is acting. Okay. And then M. What is M, guys?
Telepathy.
Malampati grade.
Okay. So you will say, verbalize to the patient. Can you open your mouth? I will assess Malampati score. Thank you. Then O. What is O?
Obesity.
Any obstruction
Obstruction.
in the neck.
Yes,
Obstruction.
I will check for any obstruction, any abscess, any neck collar, nothing. Okay. And then N, neck mobility. Okay. So I will check for neck mobility. So can you move your neck, right, and left? Thank you. Even the patient is not responding, just verbalize. Okay. We finished now ample history. So how to talk about ample in patient? In nurse, it will be easy. Just verbalize to the nurse, check, take ample history, do lemon assessment, and check as a classification. For the patient, how to ask about ample history? You can tell him, I need to take some data from you to see if you have any contraindication. Okay, so you will ask him about A, allergy. Do you have any allergy? And then M, any past medical disease, any previous prescribed medication. So M for medical and medicine. Okay. And then what is
Past
ample?
medical history.
Past.
P for past medical history.
Okay. And L, last date and drink.
Last meal and event.
Now I'm trying to explain to you guys the communication skills. So if the station teaching the nurse, you have communication skills. And if the station take consent from the patient, different communication skills, right? Okay. So
Yes.
here the same station, but different in communication. Okay. And in nurses, they will put teaching skills. In patient, they will not put teaching skills. Okay. Okay. So here, regarding the procedure, you will be in a monitored area. You will give the sedation and you mention the name of the sedation. You have two options, propofol and fentanyl or midazolam, and you have to prepare the antidote. So you will mention the doses and the antidote. Okay. Regarding the staff, minimum 3 staff. One for airway, one for sedation, one for reduction. Okay. So you will be for airway, and doctor of bone for reduction, and the nurse for cannula medications. Okay. So here we are inside the procedure. We are in the point of during. So we finished before and then during and then after. We are now in the point of during. Okay. So during here, you will give the patient oxygen, you will give some fluids, and then medications, and you will do the reduction. So the reduction here, it means in the procedure, during the procedure. Okay. So reduction, you are not expected to talk about the reduction. Okay. So if you are teaching the nurse, you can say to the nurse, you have many procedures of reduction. I will teach you one of them, and you can do. Okay. Regarding the patient, no need to do specific reduction, because maybe you will tell the patient about one technique, and your colleague, he will come after sedation, he will do different technique. So it means you are giving him wrong information. But if you want to say, you can say like that. There is many techniques. Okay, I will show you one of them. So it will be logic in front of the examiner. You will understand that you are giving him one of the techniques. Okay. After the procedure, whatever to the nurse or to the patient, so the patient should be observed in monitored area in recovery room, check vital signs, no pain, no respiratory compromise. Because we are talking about sedation. We are talking about reduction. We are talking about dislocation. So the two important points, pain, because dislocation. We are talking about sedation, so respiratory compromise. So the patient should return to baseline. Pain and respiratory compromise should be addressed. Okay. Then should be discharged after 4 hours. If normal, with third party, no no signature, no driving. Clear, May and Rian?
Yes, sir. Yes.
You see the difference if you are talking to nurse or you are talking to patient?
Okay.
Okay. Yes. If you are talking about the indication, for the patient, you can say we need to do this procedure because you have problem in your shoulder dislocation. That's why we need to do reduction. It's painful. That's why we need to give you sedation, medication to depress your awareness. No need to talk about DC shock. No need to talk about sutures because it's not relevant here. Clear? But for my, you can teach the nurse about the indication. You can say if any dislocation, if any synchronized DC shock, if any sutures. Clear?
Yes, clear.
Okay. So you have 30 seconds in 6 minutes. Please, guys, we need your feedback for May and Diane, and give us marks for them. Okay? And if they miss any point, you can mention later.
Okay, can I start?
You can start.
Hello, good morning. I'm Dr. May, ED Registrar. May I confirm your name and level, please? Okay, thank you. Nice to meet you. I believe we have something to discuss today about conscious vision. Okay, it's really interesting topic here in ER. So, how much do you know so far? Okay, any specific point we want us to focus on it? Okay, so today we'll discuss you about this, and I will give you later websites, videos you can learn more from it. Okay, so Dr. Sami, we have like the pre-measurement of during and post-measurement. Pre-measurement we have on it. I will discuss with you about it. It's include like indication for the procedure itself, complication, the contraindication for the procedure. Okay, so I will go one by one. Okay, just follow with me, and if you have any question, just feel free to ask me at any point. Okay, so for the indication, if we have like a painful procedure we wanted to do and the patient is conscious, like reduction as we have here. I think you have patient right now. Okay, so no patient. Okay, good. So if we have like one patient with we want to do joint reduction for him, like we need to give shock. In that case, we can give the conscious sedation to the patient. Regarding the contraindication, it will be like if the procedure is need like general anesthesia, or we have child less than 1 year, or we have difficult airway. At that time we can do the conscious sedation. Okay, for the complication, from a complication, if the patient has like allergy from the medication itself, or the patient refuse, or um, uh, or a toxin from the overdose. Okay, so this regarding pre procedure. Okay, during the procedure itself, it's divided into two. We have preparation and we have the procedure itself. For the preparation, we have to prepare ourselves as the doctor. We have to prepare the patient himself, and we have to prepare our equipment. For us, we have to wash our hands, wear our gloves, wear our PPE, and like that. For the patient, we have like to take first of all explain the procedure for the patient, what we need from this procedure, and take brief history from him. Brief history in the form of ample. Ample, it's for allergy, M for medications, B for past medical history, and L for last meal, and E for the event, what happened to him exactly. Okay. So, and then you have to assess the patient airway, assessed by Lemon. Okay, L for I will teach you all this in details. Okay, so Lemon, this for how to do it. L for look, you have to look for the patient neck if there is any deformity, abnormality, short of the neck or anything, and if you have any like inside the mouth any foreign body or something like this. E for evaluation, you have to evaluate by 332. Okay, I will teach you how to do it later. Okay, and M for the Melapathy score, we have something called Melapathy score. This for that you have to see inside the mouth if you have clear airway or difficult airway. Okay, and we have also as a classification, O for obstruction, if there is anything like a pain, trauma, abscess, anything that close the neck. Okay, and what is it? And the last thing is okay, Lemon. Okay, the last thing is an N for neck mobility. Okay, you have to ask the patient to move his neck. Okay, do flexion and extension. Are you following me so far, doctor? Okay, any questions here? Okay, good. So, and you have also to review the X-ray for this patient. So, this for the patient. For the medication and equipment, we have to prepare trolley and ambobagging IV access, monitoring 12 lead ECG. Okay, and we have like we need 2 doctors and 1 nurse. Okay, nurse for medication, and a doctor for the procedure itself, and one doctor for the assessment. Okay, so regarding medication, we have so many types of medication. It will give you like ketamine, as for example. The dosage will be 1 mg per kg. Okay, and you have to calculate the dose very well. Okay, after that, and you have to keep the antidote beside you in case if there is anything happen to this patient. Okay, now we come to procedure itself. We have so many methods or type for like here we have if we have like shoulder reduction, for example. So you have many so many procedure for it. For example, you can do coher methods. Okay, I will give you good details about it, how to do it. Okay, in the future. So so Dr. Sami, anything difficult till now? Okay, good. So now we come to what is it the post procedure measurement. When you finish, okay, you have to be sure the patient is able to talk, to walk, okay, check his vital signs, blood pressure and saturation, respiratory rate, GCS of the patient. All these vital signs should be returned to normal, okay, and at the end, after discharge, we will give him like advice, okay, not to drive or not to be like sign any paper like for 24 hours, okay, and also he has to be
Thank you.
confined with.
Thank you. Your time done.
Okay,
How many marks, guys, you will give mine?
9 to 10.
MashaAllah, 9 to 10.
Okay. She is talking in details. No need for details here. So, for example, if you will say you will take data for ample history, do Lemon assessment to check any contraindication for difficulty airway, um, check ASA classification. No need to mention the details. Okay.
okay,
Yeah. Here regarding preparation, so you will examine the patient, put in monitor the area. You will prepare medication, and you will mention all the medications, the doses. Better
okay,
to mention propofol here or midazolam. No need to mention ketamine. Okay.
okay,
Yes. Also, during you should emphasize on minimum three stuff. Um, you will give the patient oxygen, some fluids, to IV access. You have to emphasize on these points because it's for safety, right? The patient will be in lying flat or whatever, semi-sitting position, no problem. Uh, Then you will do the procedure. It means you will give the patient the sedation and then you will do the procedure. After the procedure, I think you covered almost everything. So I think you are doing well. Thank you. So I will give you 8 marks.
thank you.
Well done. Next one, Diane.
Hi, Catherine.
So your task, I will remove teaching, no teaching here, okay?
No problem.
And you will take consent instead of teaching. I will change take consent from the patient to do sedation, and your colleague will do reduction. Clear?
Yeah, sure.
Okay. So you have 30 seconds and 60 minutes. Of course, as a patient, you have to tell him, I'm here. So after introduction, after rubber, empathy, sympathy, check comfortability, check pain. Also, you will tell him, I am here to take consent from you regarding one procedure. It's called sedation. I will explain all information to you. Clear now? In the end, if he accepted, you can ask him, is that okay with you? If he said yes, can you sign here? Okay. So you should talk about indications, contraindication, complication, how to avoid and treat complications, and then alternatives. What is the alternative here, guys?
His options would be one, we do nothing. Two, deconscious sedation, or three, general anesthesia.
Scapular block,
Local anesthesia.
local anesthesia, injection into the joint.
General
So now you are doing procedural sedation. It means you are giving sedation through the vein, but low dose. That's why it will decrease the awareness or depress the awareness. But the alternative here to give high dose, the same medication, but double dose, so he will go in deep sedation. Okay, so you can take him like that. We can double the dose to make you in deep sedation in general anesthesia. Okay, but this one needs to support the airway. We need to insert a tube in your lung. Okay, another alternative, we will give you local anesthesia. It means we will give injection inside your joint, shoulder, to numb the shoulder. Clear?
Yes, sir.
Okay. So anyway, you have 30 seconds and 6 minutes. You can start.
Hi, good afternoon. My name is Dr. Diane. I'm one of the ED registrars on the floor. Could I have your name and age, please? Hi. I would just like to talk to you for a little while. But before we do that, are you comfortable? Are you in any pain? I will give you some painkillers as long as you're not allergic to anything. I'll ask you nurses too. Just briefly though, are you allergic to anything? And do you have any past medical history or any chronic medical conditions that you're aware of? No? Do you take any medication? And when was the last time you had a meal to eat? Okay, do you can you just tell me briefly about what happened today to make you come to hospital? Okay, no problem. How much do you know about what's going on? Like what happened to the shoulder? Yeah, so you understand that the joint is out of place. I was asked to come and just take consent fee from you to provide something called conscious sedation to reduce your shoulder. Now that's a big word, and I'll try to break it down as best as I could. If you have any questions, you could stop me and just let me know. Now, what we want to do is we want to address the pain, as well as the anxiety that you would have from trying to put the shoulder back into place. Now, this is our procedure that we do routinely. We give you medication, something called midazolam and propofol, at a dose that will cause you to have a little bit of a depressed awareness, so you wouldn't really remember what's happening, and you wouldn't really have the pain of what is going on when we start to do the procedure. Now we will keep you in a monitored room. We will put you on some oxygen, set up 2 drip lines, 2 IVs, and start some fluids on you as well. We will have we'll have 2 extra members of staff present as well, somebody to manage your medication and somebody to to actually do the reduction. Now, and something to manage the airway as well. Sorry, sir. Now, before we do that though, we'll just have to go through quickly what if you have any contraindications to the procedure. It's just a quick little screening that we would have to do. So I would just need to know, I would just need to examine your neck a little. I just want to take a look at your face and neck in case we do need to go through to manage the airway a little bit better. So we'll want to look to see if there's any facial deformities that you would have had, or any issues with the teeth or the mouth, even something like a beard that you would have had. I would just want to ask you to, well, I know this sounds a little bit daunting, but just to say, well, to see whether and how wide you could open your mouth and the spaces between your chin and your throat as well. I would just ask you to open your mouth as well so I can see how far back into the throat we can see. Right. I would want to know whether or not you would have anything that could cause any obstruction. So anything that could make the sedation a little bit difficult for us. Right. And as well as how well you can move your mouth. Right. I'm sorry, not your mouth, your neck. Now during this procedure, once that's okay, I just want to know whether or not you have any chronic medical conditions that would in general affect your daily life. And once that's okay, once all that is fine, we will proceed to do the sedation, and then put the shoulder back into place. Now, I know it still sounds a little bit scary, and I am sorry about that. I am trying to break it down as well as I could. Now, but to make sure that you're with me so far, right? We just want to do a quick screening to give you the proper medication. Now, with respect to the medication, we will have you in a monitored room. So we will have all your vitals before we start, as soon as we give you the medication, a couple of minutes after, and we will keep you in this monitored room even after the procedure until the sedation has worn off. So once you can breathe properly, once your consciousness level has returned to normal, and once the pain is manageable as well. Now, after this, once all this is successful, we'll have to repeat some extras of the shoulder. And I would advise you very much so that when we are discharging you, we will send you home with some printed leaflets as well. But I would rather, well, actually, we strongly suggest that you go home with someone who can take care of you for at least a week. You wouldn't be able to drive or operate heavy machinery for a week. You may be a little bit drowsy, and we'd rather you not sign any important documents for about a week. Yeah. Do you have any questions so far? No? Okay. So with respect to this contrast sedation, there are some complications that could occur. Now, the sedation could be a little bit deeper than we expect it to be. Some people react to the medication a little bit, or who are a little bit more sensitive to it. In that case,
Thank you. Thank you. Your time done. Excellent.
Thank you, sir.
Yeah. Yeah. Okay. Thank you. How many marks, guys, will give there?
9.
Okay. Any missed point?
I think the benefits not explained if we give the sedation and the alternatives.
Okay. So I will give feedback. In the beginning, she jumped to ample history, right?
Yes.
In the beginning, she jumped to ample history. So try to be supportive. So you should introduce yourself. After that, may I know your name and age? After that, nice to meet you, Robert. I'm here to take consent from you. I will explain everything to you and then check comfortability. Are you comfortable? Do you have any pain? Okay. Then you will discuss about the procedure. Okay. So I will explain to you the indications, the contraindications, the complication, and the procedure. You should mention that to the patient, to the actor. Okay. After that, you will go for indication. Okay. Don't talk about amble. Amble in indication or in contraindication, guys?
Contraindication, sir.
Yes. So amble, lemon, and ASA classification in contraindication. So ignore now. Now we are in the point of indication. Okay. So you can say, I'm here to take consent from you regarding one procedure. It's called sedation because you have problem in your shoulder, and for this reason we need to do reduction to fix that. It's very painful. For this reason I need to give you medicine to depress your awareness, which is called conscious sedation. Clear now? No need to talk about the types of sedation because he is patient. Why you will discuss with him about all types of sedation, not logic. But in teaching in nurse, you have to give her information about the 4 types of sedation. Clear, guys? This point?
Yes, sir.
So with nurse, you can tell her about types of sedation. In indication, you can discuss all indications, like this is shock, like suturing, like that. Okay? Wait seconds, guys. Okay, guys. So with nurse, you can give her different information apart from dislocation. But for patient, why you will discuss about this shock? That's not logic. Okay. So anyway, so for this reason, I will give you medicine, sedation, which depress your awareness, so you will not feel the pain. We finished now the indication. We will go for contraindication. You can tell him like that. I need to take some data from you and examine your airway, or at least you can say, and assess your airway to see if you have any,
Indications.
Obstructions or
contraindication.
contraindication. Yes.
Okay? So I need to take some data from you and assess your airway to see if you have any contraindication. So now I'm caring about what?
Communication.
Communication.
Skills. How you are talking to the actor, to the patient now. Okay? Do you have any allergy? Do you have any blah 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 blah? So can you see the difference at the end?
Yes, sir.
In your practice, you jump in the beginning to ample history, not logic. Clear? Okay. So after you finish ample, after you finish lemon assessment, after you finish ASA classification, no need to do, but you can verbalize to the examiner. I will ask about ASA classification as well, but no need to ask. Okay?
Okay.
Just turn your head to the examiner and tell him, ideally, I should ask for ASA classification of the patient. Once you mention of the patient, the examiner will understand you are talking to him. Clear now?
Yes, sir.
Okay. Then we finished now the contraindication. Then the complication. You can tell him it has some complication. You might go in deep sedation. Okay. And also some complication from the reduction, like fracture or failed reduction. Done. More than enough. How to prevent that? We will give you accurate dose of um, medicines. Okay. And we are expert enough to avoid any complication. More than enough. We have alternatives, blah, 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 as we mentioned earlier. Okay. The procedure, you will be in monitored area. We will attach you to oxygen. We will give you some oxygen. We will put heart monitor to your chest to observe you. And we will give you insert to IV access. We will give you some fluids. And we will give you medicines to depress your awareness. Please, nurse, can you see? When I talk about the medicine, I will talk to the patient or the nurse?
No.
There. Please, nurse, prepare whatever. If you want to mention propofol and fentanyl, or you want to mention midazolam, it's up to you. Then you will tell him we should be minimum 3 staff. Me, I will assess your airway and I will care about your airway. And one doctor, he will do reduction for your shoulder. And one nurse give you sedation and give you fluids. Clear now? Okay. After the procedure, you will be in recovery room. We will observe you and we will check your vital signs should return to baseline and no pain, no respiratory problem, no nausea, no vomiting. Okay. Then we will, after 4 hours, we will give you printed leaflet if you are okay and advice. Blah 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 blah, as we mentioned earlier. Clear, guys, this station?
Yes, sir.
Yes, sir.
Yes, sir. Excellent.
Yes.
Yes, Dr.
Well done. I will give you 8 marks there.
Thank you, sir.
Welcome. Okay, next one. Zishan.
Yes, boss. So,
Yes. Okay. If the nurse show you X-ray, it means you should teach here about the X-ray also. Clear?
okay.
If they show you X-ray, it means for a reason. If
Mm,
if the nurse said no X-ray, it means they don't care about teaching X-ray. I want you to understand the examiner. I want you to understand the Royal College mind. Clear?
okay.
In any station, if they give you ECG for a reason or not,
Yes.
if they give you ABG for a reason or not,
Right.
okay. If you go for this station and the task is talk to the actor, to the patient, and take consent. So before you go and approach the patient, ask the examiner any available X-ray. If he said yes, it means what? You will show the X-ray to the patient, right?
Right.
If they said no available X-ray, it means they don't care about the X-ray. Clear now?
Right.
But you should verbalize, I need to be sure the patient has dislocation. I need to check the X-ray. Just verbalize, but don't insist. Don't argue with the examiner. Okay, well done. So we will go for next station. Okay, this one is the same. Okay, so this one, knee joint aspiration. It will be the same idea. Okay, so the landmarks here, you will insert on the lateral side 2 centimeter lateral to the lateral border of patella. The direction you will insert inferior and posterior, just beneath to the patella. You will use 3 needles, 1 small needle for injection of lidocaine anesthesia, another one for aspiration long needle, and different needle for injection any medicines. Clear?
Okay. Yes.
You will use how many tube?
3 tube. Okay.
Okay, so here you will use 1 tube. Okay, you will check the color, clarity, viscosity. You will check what?
Or
Color,
clarity.
Clarity and
viscosity.
viscosity.
By your eyes, gross
Mm.
appearance. And you will send to the lab for what? White BC,
WBC.
differential,
Differential.
crystals, gram stain, culture. So 1, 2, 3, 4. And you will check by your eyes for 3 points. Then in the exams, you will show you any of them. Okay? So if you find this one clear, it means a normal. So no problem, you can discharge the patient. If you find this one, it means non-inflammatory. If you find this one, so inflammatory. This one, septic. This one, hemorrhagic. Clear?
Mm.
Okay, you have 30 seconds, then 6 minutes. Your task teaches the junior doctor. You have mannequin, teaches the junior doctor about knee aspiration.
Okay, my name is Dr. Zishan. I'm ED registrar. May I confirm your name and the position, please? Okay, you're junior general house officer. Okay, nice to meet you. I believe that you have any concern. You are here to learn about the knee aspiration. Okay, that's good. It's a very important topic and it's a very day-to-day practice topic and in the emergency department. I'm happy that you are here. So do you have any previous knowledge about this procedure? No. Okay. So do you want to know anything specific about this topic? Okay. Okay. Before I will give you the I will start my procedure. I would like to know that if you have any active patient with you, or have you handed over your patient to your colleague, so the patient is safe. Okay, fine. So we have here, mannequin here. So I will tell you about I will start that I will teach you. I will give you the plan, the objective that I will give you the indication, the contraindication about. I will tell you about the contraindication, complication, and how to prevent the complication, about the procedure, and the post-procedural advice and complication. So here we have the mannequin here. First of all, we will start from the inspection. First, we will do the take a brief history about the patient. Then you will do the inspection, brief inspection, and if there's any swelling, warmth, any change of color, anything, then you will apply the sterile drip and the and then you will this one the site for the aspiration is 2 centimeter lateral to the patella. So, but the indication, what is the indication of why you will do this procedure is when you have any doubt that either the patient has septic arthritis, osteoarthritis, or any inflammation going on in the knee. The patient came with a severe pain and the swelling and the redness and maybe the patient is febrile, there's the indication. Okay. Then the contraindication, if you have any sign of cellulitis, any sign of infection at the site of the aspiration site. The contraindication, the contraindication, the complication, then if patient may develop the hemarthrosis or something, and also the contraindication if the patient has the bleeding disorder or a patient is on the any anticoagulant, so that is also a contraindication. Complication may develop, maybe hemarthrosis, maybe there is some bleeding or swelling after this procedure in the pain. So how to prevent this one? We can do the, although we have a landmark, which is very simple procedure, but still we can do the ultrasonic guided procedure also. So how we will do it, that we will take a, we will first instill the lidocaine, 3 milligram per kg with a small needle. Almost we are taking 24 gauge needle, small needle. First we will instill this one lidocaine some quantity to give the analgesia. Take the consent first before doing these things, and then after that take the middle size needle. Almost you can take a 20 gauge needle for the aspiration of the fluid. And in case if you have to give any antibiotic in between the joints, so that you can use the large needle like 16 or 18. So these are the things. And after this, if you have, you have to collect in only one bottle, one test tube. So the color will also differentiate you about the, you will see, first of all, you will see the clarity, the color and the viscosity. If it is transparent, so it is normal. If it is slightly, yeah, slightly heavy, so it may be, it is non-inflammatory, which is osteoarthritis. And if it is opaque and it is different color, then it is inflammatory, most likely from the rheumatoid arthritis, or maybe because of the septic arthritis. And you will send this one for the microscopy. You need only one test tube for the WBC, for the crystal, gram staining, and the culture. So these are this is how you collect it. After that, you just apply the. After that, you just apply the gauze and do the dressing again. After this extraction, give the instruction to the patient about the post-operative procedure care, and the patient doesn't need to walk too much. Just try to avoid walking too much in the couple of days, and the weight bearing. And then if there's any complication, advise them to come to the ER. Do you have any further question? Do you understand anything? If you need any further question, I am here around. And whenever you do this procedure, you can ask me. I will do the practical procedure with you. I will give you some leaflets also, so that you can read it, and I will give you outside also. Thank you.
So what about this tube? So what
Yes,
is the,
this is,
what is
yeah,
the method?
this is for the, it shows that the patient is has the gonococcal septic arthritis. So the patient in the septic arthritis. So of course, in this condition, we may need to give the antibiotic also.
Thank
So
you.
thank
Thank
you.
you. Okay.
MashaAllah. Excellent.
Okay.
10/10.
Well done. So if they show you in the exam tube like that, no need to say gonococcal. We don't have idea. Why? This example, right?
Right.
Example. Don't mention. You can say it seems like sepsis more than that. Okay. So
Okay, thank you.
you have to give the patient broad spectrum antibiotic. So you have to follow 3 in, 3 out. Okay. You have to wait for the culture, but first you have to, after the culture, you will give broad spectrum antibiotic, and according to the culture results, you will see if you continue the broad spectrum antibiotic or you will change the antibiotic. Okay.
Okay, thank you, sir.
And welcome. And according to the vital signs, according to the systemic manifestation, you will see if the patient needs admission or not. Okay, well done.
Thank you, sir.
Okay, next one. I will give you 9 marks. Next one, Farzin.
Thank you very much, sir.
So backslap application, in the exam, you have to do. Okay.
Okay.
So they will give you equipment in the exam. They will give you equipment, stockinette, plaster, bandage, padding, bandage, warm water. I want you guys to do in your hospital. It's very easy. Just you will put the stockinette, you will apply stockinette. So you will apply stockinette. Number 2, number 2. What is number 2,
Padding.
guys?
Apply the padding.
Padding. Soft bandage.
Okay, so number 2, you will put the cotton bag. Number 3, the plaster. Number 4, you will do unfolding, and then
Grip bandage.
Then
Rabbit with grip bandages.
yes. So first of all, you have to put in your mind the steps. Number 1,
apply the stockinette.
stockinette. Number 2,
The bandage.
Cotton padding.
Cotton bandage.
cotton bandage. Number
Cotton
3,
padding.
Plaster.
POP.
Plaster bandage.
okay. And after unfolding, you will put the grip bandage.
Grip bandage.
Okay. So we still have the size. How to put the, please, you have noise, Farzin. Okay, so here you will cut 10 centimeter proximal to the elbow and 5 centimeter distal to the metacarpopharyngeal joints. Okay, how to make opening here? You will just hold the stockinette at the base of the thumb here, from here, and then pull and cut this part. It will be like that. Okay. Or you can make another option. So you can pull the stockinette until the end of the thumb, the top, and you can cut this point and you can leave, it will be opening like that. Can you imagine, guys?
Yes, sir.
Yes, sir.
Yeah. So, for example, if it's not cut like this one, you will just pull the stockinette here at the top of the thumb and then cut above the thumb and leave, it will be opening like that. Okay. So regarding this one, how many centimeter proximal to the elbow?
5.
5 centimeter.
10.
10 centimeters.
And how many centimeter proximal to the metacarpopharyngeal joint?
Knuckle.
5.
5.
10, 5. 10, 5. Okay. So it's easy. Number 1, stockinette. 10, 5. And the make cut. Okay. Number 2, you will apply cotton bag from the elbow to metacarpopharyngeal joint. From the elbow to metacarpopharyngeal joints, and don't cover any finger. Don't cover the thumb. Don't cover other fingers. It's easy. Okay. Number 3, you will apply what?
Plaster bandage.
Plaster. Okay. So you should cut the plaster, you should size first. You will size below the elbow, how many centimeters?
5 centimeters.
5 centimeter below the elbow.
Yes.
Okay. And at the level of metacarpopharyngeal joints. So you will size from here to here, and then you will cut like 6 or 8 layers. Then put on water, warm water. After that, you will put on the arm. So the arm should be in extension and pronation or supination.
Pronation.
Supination. Supination.
Supination.
Pronation.
This
Sorry.
one?
Pronation.
Pronation.
Yeah.
Okay. So the most important, guys, the steps. You are not orthopedic doctor. They know you are not orthopedic doctor. So they care about the steps. I mean, the patient should be standing and you will keep his arm in extension, pronation, and you will put a stockinette. After that, cotton pad. After that, plaster in warm water, and after that, you will put on the arm, on the dorsum, Okay. So, is it correct? Is it accurate? It's not a big issue. You will get high score if you will do the steps. It's not about very smooth or very accurate. No, it's not a big issue. Don't worry. Okay. So after that, you will smooth by 2 hands. After that, you will unfold the 10 centimeter and the 5 centimeter like that. Okay. Easy.
Yes, sir. Thank you.
Okay. So when you ask the nurse in the beginning, so you will go inside the room, you will find 2 actors, one nurse and one patient, not mannequin, actor. Okay, you will find 2 actors. If you find any nurse in any station, talk to the nurse first. Clear?
Yes, sir.
If you find 2 actors in the exam, one nurse, one patient, to talk to the nurse first, like you are doing in real practice. So, how you approach this station? You will go inside the room, ignore the patient, go for the nurse. Good morning. I'm Dr. Blah blah blah, one of the ED doctors or ED seniors. May I know your name and level? Nice to meet you, Robert. I believe you have one patient for what?
Back slab application.
That is lab application. Excellent. Okay, he has fracture in his wrist. Okay. Can you prepare what? Number one?
Equipments for the back labs. Yes.
Equipment, yes. Number one?
Stockinette, cotton padding, plaster bandage, and crepe bandage.
Stockinette, cotton pads, plaster, and
Crepe
warm
bandage.
water and crepe bandage.
excellent. Okay. Easy
Yes, sir.
and warm water. Okay. So ignore the nurse. You will go for
Patient.
patient. Good morning. I'm Dr. Blah blah blah, one of the ED seniors. I believe you have fracture in your wrist. For this reason, I'm here to do back slap.
Back slab.
Are you comfortable? Do you have any pain? So nice to meet you and blah blah blah. Okay. So the same. I'm Dr. Blah blah blah. May I know your name and age, please? Nice to meet you, Robert. I believe you have blah blah blah. Are you comfortable? Do you have any pain? The same idea. Okay. So you will ask him, can you stand, please? He will stand. Can you do like that? So I want you to make like that, guys, and he will do the same. So show the patient the position. I want you to make like that, and he will do the same. Okay. Then you will measure the stockinette from here to here, and then you can apply. Okay. Number 2, cotton pads. Number 3, the plaster bandage on water, 8 layers. This station you have to do, not verbalization. You have to do and verbalize as well. Okay, clear, Farzin?
Yes, sir.
Okay, so after you finish in the end, you will do back arm sling. So he will put his arm on his chest and you will do arm sling and give him printed leaflet with a charge letter to his GP. And you will give him advice. You have noise, Farzin, please. Farzin, can you hear me?
Yes, sir.
You have noise beside you. For me, no problem.
Sir.
For your colleagues. Okay.
Okay, sir.
So here regarding this station, you have to give advice. So he should follow up with fall clinic or fracture clinic. Okay. He will remove within 4 to 6 weeks. And he can return to ER if he has any worrying symptoms. And you can mention him to him the worrying symptoms like severe pain, any swelling, any change in color, and so on. Okay. Any number,
Okay, sir.
weakness, anything like that. Okay. After applying this one, you should ask him, can you move your fingers or can you wiggle your fingers? Okay. You have 30 seconds, then 60 minutes. Okay. So you have nurse and the patient.
Okay, sir. Sir, should I start?
Okay.
Hello, good morning. I'm Dr. Frazeen Shahid, one of the ED doctors. May I know your name and grade, please? I believe you are here to learn. I believe you have a patient for a back slab application because the patient had a broken bone in the arm. Is that right? Okay. Nice to meet you. I need you to prepare equipment for me, which includes you have to prepare these stockinets, cotton bandage, and prepare the plaster bandage, warm water, and a gray bandage. Okay, thank you. Now I will just move towards the patient. Hello, good morning, sir. I'm Dr. Frazeen Shahid, one of the ED doctors. May I know your name and age, please? Nice to meet you, sir. I am here. How can I help you, sir? Are you comfortable? Do you have any pain? Okay. Sir, I'm here to apply a back slab on you as you have as your bone got broken in your arm, and I'm going to do a procedure and it's called as a back slab application. So is that okay, sir? Sir, I will explain everything in detail, including the indications, contraindications, complications of the procedure, and how to avoid the complications, and the details of the procedure itself. And I will do the procedure on you. Okay, and I will also guide you regarding the post-procedure care as well. So regarding the indications, as I told you, and any broken bone in the arm, we can do this procedure, and the contraindications for this procedure is any open fracture or infection at the site of the procedure. We should not be doing this procedure, or a patient has any problem with the nerves or the vessels. And regarding the complications, which can happen after the procedures, include the worsening of the pain. Patient can present with a malunion of the bones or a non-union of the bone, or there could be damage of the vessels of the or the nerves. Is that clear, sir? Anything you want to ask till now? And okay, and we can prevent the complications if there is an experienced person who can do this procedure. So the complications can be provided in this case. Now, sir, I will start with the procedure. First of all, I need you to stand for me and extend your forearm, your palm facing downwards. Okay, thank you. First of all, sir, I will need to measure the things which we need to apply on your forearm for a back slab application. First of all, I need to measure the stockinette. It should be measured required from the 10 centimeter distal to the olecranon of the elbow and 10 centimeter distal to the metacarpal phalangeal joint on the hands. And afterwards, I will measure the cotton bandage, that is the padding, and it has to be measured 5 centimeter distal to the olecranon of the elbow and 5 centimeter proximal to the metacarpophalangeal joint on the hand. And after measuring these two, first of all, I will apply the stockinette. I will make a hole in the stockinette for the thumb, and after applying the stockinette, I will do the bandage with the I will do the padding with the cotton bandage, and I will cover I will cover about 50% of the previous stockinette from the elbow to the metacarpophalangeal joint, and I will cover distal to the olecranon and proximal to the metacarpophalangeal joint, leaving the thumb out while applying the banding as well. Now I will measure the plaster, and the plaster should be measured the same from the level of the olecranon to the metacarpophalangeal joint. After measurement of the plaster, I will make 6 to 8 layers of it, and I will soak it in the warm water, and I will gently squeeze the warm water from it, and I will keep it on the dorsum of your forehand, and I will keep the forehand and I will try to keep your forehand in a slightly semi-flexed or pronated position. And afterwards, I will apply 6 to 8 layers of the plaster. And after application of the 6 to 8 layers, I will smooth out the plaster with the help of the palm of my hand. And later on, I have to apply a crepe bandage over the plaster. Then I will wrap the excess of the stockinette over the plaster so that the rough edges of the plaster don't damage your skin. Okay, sir. So and now that I have applied the back slab, sir, can you please try to move your fingers for me? Okay, that's good. Are you comfortable? Do you have any pain? Okay. Now, sir, I will place your arm in the arm sling, and I will keep it and I will try to keep it in immobilized position. Now as I have finished the procedure, so sir, I will give you a printed leaflet and a discharge letter for your GP. And if you have any worrying signs like pain, any worsening pain, any worsening swelling in your arm or on your hand, or if you feel any problem in your vessels or in your nerves, you can come back. And sir, I will also I will advise you to not to put some weight on the plaster. Keep it dry for 24 hours. And I will give you a appointment for a fracture clinic. You can visit them after 4 to 6 weeks, and they will remove the plaster, and they will manage you accordingly. Or And sir, do you have any questions? Okay, sir, thank you. I finished my procedure.
Thank you, Farzin. Thank you. You still have 35 seconds. What do you think, guys? How many marks?
Excellent. 10, sir.
Okay, 10. Are you happy with the approach?
Yes, we are happy with the approach, and
Yes.
excellent.
Well done. Thank you, Farzin.
Okay.
You did
Thanks.
very well.
Thanks a lot, sir.
Yeah. So I think it's very clear, but in the exam you have to do, okay?
Yes, sir.
You verbalized within almost 5 minutes. You still have 3 minutes, so you don't have problem in time management in the exam, inshallah. Okay?
Okay, sir. Inshallah, sir. Thank you, sir.
Welcome. Omar? Omar,
Yes, sir.
how are you?
I'm fine, sir.
Okay. This station splint and slings. Splint and slings. Okay. Are you familiar with that?
Yeah. Yes, sir.
Okay. So we have 4 types. In the exams, they will give you this triangular sling. This triangular sling you can use for broad and for what? High.
Good.
Arm sling, high arm sling. Okay. So broad, which letter?
B.
B.
And
B.
below which letter?
B.
B also.
Excellent. Excellent.
So broad, it means below. And high, it means above. Clear?
Yes, sir.
So broad, it means below, and high, it means above. Okay. So if you want to use the same triangular as broad, it means the hand below
Shoulder.
Below
shoulder,
the clavicle. Yes.
below the shoulder, and the sling below the hand. Easy?
Easy.
Yeah.
Excellent.
Okay. So again, broad, B letter, it means below, B letter also. So the hand will be down the shoulder below, and the sling will be below. Okay. So you have three angles. One angle to the elbow, one angle to the shoulder, one angle in the same side of the shoulder. Easy?
Easy.
Then you can apply this angle the opposite above because it was below, right? Then this one will be above like that. And then you can tie from back. I think it's easy. Okay. Okay, so this one um, will be from the back. Okay. We will go for high arm sling. What does it mean high?
High
Above
means
the
the
shoulder.
arms are high.
Above. It means
Above.
the
Above the shoulder.
hand above what?
Shoulder.
Shoulder.
And the sling above what?
Above on
Hand.
its front.
Above the
Above
hand.
the hand.
Above the hand.
Above the hand. Okay. The last one, it was broad, B. It means the hand below the shoulder. And the
Yes,
sling
sir.
below the hand, right?
Yes, sir.
This one's the opposite. High, it means the hand above
Shoulder.
shoulder. And the sling above
The hand.
the
Above
hand.
the hand.
Clear now?
Yes, sir.
Three angles. One angle at the elbow, one
I
angle.
didn't understand that.
Please mute your mic, guys. One angle at the elbow, one angle at the shoulder, the same shoulder or the contralateral shoulder?
Opposite shoulder.
Opposite. Opposite,
Contralateral.
yes.
Contralateral. Okay. So one angle to the elbow, one angle contralateral shoulder, and one angle to the same shoulder. Okay? Okay. And then you will apply the angle to the opposite. It was here above. It will be
Below that.
below, yes. So you will give below the elbow because it was above here, right? So
Yes,
you will
sir.
the opposite. And then from behind you will make tie. Clear?
Yes, sir.
Okay, I will recap again. So we have the same arm sling. You can use as broad or you can use as
Nicely.
high arm sling. So broad arm sling or high arm sling. Broad, B letter. So the hand will be
To the shoulder.
Below the shoulder.
and the
Arm.
sling will be
And sling below the shoulder, below the arm.
below the hand. Okay. And then one angle at the elbow, one angle at the shoulder, contralateral, and one angle down the same shoulder. This one below. So when you tie, you can bring the angle the opposite. So this one below, this one will be above, right?
Yes, sir.
Okay. And then you can tie. For above, it means the hand above what?
Above the shoulder.
And the sling above
Above the hand.
the hand. One angle at the elbow, one angle at the contralateral shoulder, one angle below or down the same shoulder. Then you will bring the angle the opposite direction. So here above, this one will be
Below.
below from. It will help you to tie from back. Clear now?
Yes, sir.
Okay. Regarding stockinette, how to use stockinette, you will measure between two extended arms for you or the patient. Your hands
Patient.
or the patient? The patient. Because you are measuring.
Patient.
You ask the patient to measure. If the patient has a fracture, if the patient has fracture and he cannot do, you can measure for you, no problem. The same as arms of the patient. So you will cut in the middle here, in the center, easy.
Easy.
You will insert the arm of the patient from one side, starting from the center, and you will put inside until here. Don't pass to the end. No, until here. Clear? It will be
Yes.
like that. So you inserted the hand from here. Then the other part, so this part, this half here, this one, and the other half behind the patient. Can you imagine?
Yes, sir.
And you can touch. I think this one easy. So this one is called high arm sling. Stuck in it, high arm sling. What does it mean high? The hand above
Wow.
Shoulder.
shoulder. Clear now?
Yes,
Okay.
sir.
We will go for last one. What is called?
Collar and cuff sling.
Yes, collar
Collar.
arm. How to do that? You have long one without slips. So you will put around the neck and then around the wrist, and then you can make clips. Easy?
Easy, very easy.
Yes. Okay, so how many now? Four.
4.
Number one,
Broad arm sling.
broad arm sling.
Broad.
Number two,
High arm sling.
excellent, high arm sling. Number three,
Stockinette high arm sling.
yes, excellent, stockinette high arm sling. Number four,
Collar and cuff sling.
yes. Now we know how to use. Then we will talk about indications, okay? This one, long term, okay? Others, short term. Clear?
Yes, sir.
So collar and cuff, long term. Stockinette or arm sling, short term. Okay, what else? So this one we said broad, it means below. So this one for a swollen arm, for a swollen arm. But the high arm sling, it will be severe swollen arm. Easy?
Very easy.
Yes. Then we will go for stockinette high arm sling. It will be also, we said high, it means severe swollen arm. Clear?
Yes, sir.
So what is the difference between a stockinette and high arm sling? If the patient not compliant with arm sling.
Oh,
Done.
yes. Done.
Clear now?
Yes, sir.
I will recap about the indications. So this one broad means below. It means not severe. It means swollen because down, right?
Yes, sir.
Swollen arm. This one high, it means severely swollen arm. This one stockinette high arm sling means severe swollen arm. But what is the difference? If the patient not compliant
Non-compliant.
with arm sling. The three arm sling or stockinette, short term, but collar and the cuff, long term. Clear now?
Yes, sir.
And the patient has a back slap. Okay. So whose turn? Omar?
Sir, is there any contraindication for the sling?
Sorry?
Is there any contraindication? Is that open fracture?
No contraindication, but just to talk about the indications, okay?
Okay.
Yes. So the
Okay.
most
So I have to talk about the 4 things.
so here I will show you the slides, okay?
Okay.
So you will verbalize the indication. It's up to you. So your learning objectives here, this station, it will be teaching the nurse Okay.
Okay.
Maybe they will give you the nurse and the patient, or maybe the nurse only. Okay. If they will give you nurse, so you can show here the steps. It's difficult to apply on the actor in the exam, but at least show here the steps, like I verbalized, okay?
Yeah.
Okay. Um, in the exam, if they give you patient, it means you have to apply like that. Okay. So step one, you can tell here like that. Step one, broad arm sling. But don't say B, it means broad, B, it means below. No, I'm just telling you. Don't say like that in the exam, okay? So you can tell her like that. Step one, ask the patient to put the hand below the shoulder, like that. Step two, you will apply the sling below the arm. So angle to the elbow, angle above the shoulder, angle down. Then you will tie like that. Done. Okay. Clear how to mention the steps?
Yes.
Thank you very much, sir. Making it very much easy.
Yeah, thank you.
So what is the measurement of stockinette?
Sorry?
Between two
The
arms.
stockinette, how to between two arms. Okay, understood.
Okay. So it's up to you. You have two learning objectives now. Indications and the steps. Clear?
Yes, sir.
Indications and how to use, how to apply. If you want to start by indications for each one, okay. If you want to start by how to apply each one, it's up to you. Clear? Okay. So you have 30 seconds and then 6 seconds.
Hello.
Can
Hello,
start.
good morning. Okay. Hello, good morning. My name is Dr. Farooq. I'm one of the senior today. Can I confirm your name and level, please? Okay. Thank you. I understand that you want to learn something. Okay. Yeah, I'm glad to know that you want to learn about the sling, arm sling. Okay. May I know how much do you know about it? Okay. Is there anything you want to know specific? Okay. Okay. All right. So I'll be teaching you the arm sling. Okay. And at the end of our session, I'll give you some videos which will help you. And day by day, I'll be teaching you more. Okay. So let's set our learning objects. Our learning objects is the indication and application. And there are a few sling. One is the broad arm, another is high arm, another is stockinette, another is the collar arm. And I'll go one by one. Is that okay? Am I clear to you? Okay. So first of all, I will go with the broad arm sling. So first of all, I start with the indication. So the indication is the arm is there any swelling of the arm? So we need to apply this broad arm sling. So step is like we have to place our hand in the affected hand of the patient and across the body and slightly elevated position and below the shoulder. And then we have to lay down the sling under the arm as per the triangular bandage and one angle below the elbow, one angle above the shoulder, and one angle below the shoulder. And then we have to bring over the arm around the neck and we have to tie around the neck. And then we have to ensure the position of the arm and secure. Am I clear to you? Okay. And it will help you to temporary elevation. Okay. Okay. So going to the next, it is the high arm sling, and it is the indicated in severely swelling of the arm. Okay, and the procedure itself is that have to place the arm deep touching the opposite shoulder, like the affected hand to the touching the opposite shoulder. Okay, and lay the sling over the in a triangular shape over the hand, and one angle above the shoulder, one angle below the elbow and one angle below the hand. And then we have to bring the another angle below the elbow and bring it remaining fabric across the back and tie across the back. And I will have to apply a safety pin elbow to secure it. Am I clear to you? Okay. Okay. So shall we move forward? The another one is stockinette, and stockinette we have to use like when there is a severely swelling arm, but if the high arm sling is not tolerated. In this case, we have to use the stockinette. Am I clear to you? Okay. So for stockinette, we have to first of all measure the size. The size could be like in between the two arms of the patient. If patient is not take it, then we can measure it. Okay, and then we have to make a center. We have to cut in the center. We have to make a small hole in the center of the arm, and that we have to put the hand across the stockinette until the hole is goes up to the elbow. Then we have to tie out the two angle of stockinette over the shoulder. Okay, am I clear to you? Okay. So the next one is for collar and cuff. So the difference between collar and cuff and other sling is that the collar and cuff it can be used for a long time, and it can be used like fracture of humerus and also radial head fractures and other things. Okay. So the method for this collar and cuff is like put the collar and cuff over the around the neck, and another in this around the wrist, and just after that just we have to tie out. Okay. So yeah. So we do you have any question? Okay. So after that we have to after the procedure we have to make sure that the patient is comfortable, and we have to examine the neurovascular status, and we have to give some advice, and also we can give some printed leaflets according to the sling and according to what to do, and we should advise that keep the sling dry. Okay. Do you have any question?
Okay, thank you, Omar. We still have 50 seconds. Okay. What do you think, you guys? How many marks?
Full marks.
Full
Yes,
marks, sir.
10 marks. Yes. Excellent, Omar. Thank you.
Excellent. Great.
So it's a very short station, but the most important in the exam you have to apply if you have a chance. For example, if you
Yes,
feel
sir.
the actor is male, if the actor is male and you can apply, you can, no problem. Or at least you can show on yourself. Okay. If you have patient, you have to apply in the exam. So if nurse and the patient, you have to apply. Well done. Thank you. The last station, Divan.
Sir, in exam, we can choose any sling.
They will give you 3 or 4 types. So arm sling, it will be broad and high, and then stockinette, and then collar and cuff. So they will give you 3 arm sling, number 2 stockinette, number 3 collar and cuff. And for you, you can use arm sling as broad and then as high arm sling. Clear?
Sir, what I mean is if we have patient, which arm sling we need to choose?
No, she's asking for teaching. If they will ask you which one to use for the patient, so then check. If they give you any clue in the scenario, for example, they said fracture of humerus, head or neck, like that, so you can use collar and cuff.
Yeah, yes, sir, understood.
So according to the indication, if they said the patient has a swelling in the wrist, for example, or in the arm, so you will use arm sling. Clear?
Yes, sir.
Okay. So Divan, you are muted.
Sir, if it's okay, I would rather listen today. I'm not too familiar with this.
So we will stop here, guys. Inshallah, next decision will be on Saturday, okay?
Okay, sir.
We
Okay,
will
sir.
try to finish all procedures, and then we have nerve block and ECG.
Dr. Hani, can I ask something?
Yes, sure.
Sir, our exam in the last week of this January, and would we be able to finish all these before the exam and exam mock
will.
exam as well?
Yes, we will try to do our best to make more sessions, okay? And for you, you can prepare also, guys. So I'm sure you are doing your best. Listen to previous recordings and be ready for practice. Make general approaches, paper and pen in any session, whatever online or recorded, okay? And from my side, I will do my best to make many sessions before the exam, okay?
Thank you, sir.
Please, doctor. Thank you.
Yeah, okay. Thank you,
Fine,
guys.
thank you. Thank you.
Bye-bye.
Thank you, sir.
Bye.
Thank you.